appreciation to Professor Dr. Mohammed Abdul Wahab and her assistant in this great event. I hope this to be repeated again and again by you and your team. في الأول in this session of liver and biliary طبعا بنقدم الأستاذ الدكتور محمد ثروت عبد الفتاح and step to the future in bioengineered liver transplantation.
Okay. Good morning, everybody. I'm glad to be here with you, and I want to give a special thanks to Professor Dr. Khalid Safwat and Dr. Mohammed Abdul Wahab, who gave me this chance to be here in IASGO conference. First of all, I'd like to introduce myself. I'm Mohammed Sarwat, Assistant Lecturer of General Surgery at Zag University Hospitals, and Research Fellow in Mayo Clinic, Rochester, Minnesota, United States. By the way, this study was totally performed in Mayo Clinic and Neuromatrix labs. I'd like to speak today about bioengineered liver transplantation as a step for the future. As all of us know, end-stage liver disease causes approximately 2 million deaths annually, accounting for 3.5% of all deaths, and the only curative treatment is liver transplantation. When we say liver transplantation, we mean we need grafts, and this is a problem. We have increased demand and shortage in the supply. So we will increase the waiting list and get more deaths, so we will still have the problem. And we have alternative to the ordinary liver transplantation. Some say that xenogenic liver transplant is a good alternative. But unfortunately, it shows immunological incompatibility and basic variation between human and animal species, so it's rejected. Another option is isolated hepatocyte transplantation, which also show low cell engravement and loss of cell function, so it's also rejected. But with the improvement and advancement in bioengineering and regenerative medicine, we have a new bay of hope, which is bioengineered livers. Our study aims to evaluate the bioengineered liver function in vitro and in vivo, and to highlight challenges in bioengineered livers and to provide insights into possible clinical application of bioengineered livers. So we based our methodology in 4 corners: establishing bioengineered liver seeded with endothelial cells and hepatocytes, and in vitro evaluation of our bioengineered liver, establishing the swine liver transplantation model, and evaluations of function of our bioengineered liver in the swine orthotopic model. Establishing our bills. We have 3 cornerstones in establishing our bioengineered liver: decellularization and recellularization and revascularization. To know decellularization, it seeks to create biocompatible decellularized scaffold that preserves the original 3D architecture and remove the cellular material to decrease the immunological reactivity. As we see here in the picture, we have bioengineered liver, we have decellularized liver and native liver. And the decellularization can be done by physical and chemical and biological methods. And to assess the success of this decellularization, we have to quantify our DNA and make histological evaluation of the preserved liver specific microarchitecture. Decellularization, the cells are introduced into the scaffold by a variety of techniques, including injection and perfusion. And to have successful recellularization requires proper distribution of parenchymal and non-parenchymal cells. We have here an hematoxylin and eosine staining and Ki67 staining, which show that the lobular structure after receding and mitotically active cells after receding. Revascularization aims to make a sustained reperfusion to our grafts, which can be confirmed by reindustrialization and anticoagulant. Here we can summarize our BEL's formation. We have the native liver, then transform it into decellularized scaffold, then injection of endothelial cells, and 1 day later we re-inject endothelial cells through portal vein, and the seeded hepatocytes are injected through the CBD in day 12 or 14. We here accept only endothelial cell migration to sinusoidal spaces and a well-established vascular architecture. And we reject the grafts that shows blood sequestration around the portal triad and paucity of endothelial cell coverage. In vitro function are measured and scaled by taking samples from culture media of the co-cultured cells and endothelial cells group and the hep-only group. Samples are taken for endothelial cell-derived von Willebrand brand factor and albumin ammonia detoxification assay. Bills in vivo. We have our study design, which it's more to be stages than be groups. We have 3 stages. The first stage is the normal allogenic orthotopic liver transplantation stage. In this stage, it's just establishing the model. And the second stage, we have endo-only group. In this stage, we mean to measure the reperfusion of our bills. And the real experimental group is the co-seeded group, which is stage number 3. In our model, we performed an orthotopic liver transplantation model on the conventional technique, not the piggyback technique, because it can't be done in swine because there is no space between the IVC and the liver to make a dissection. So we used the orthotopic model that was previously described by Carl. Study timeline, we have received the pig at day -8 before the operation. Then we fast the donor pig 1 day before liver harvest and blood collection. And for the recipient pig, we fast them 3 days before to insert ICB in day -2. Then fast them the day before surgery and make follow-up to the pigs for 48 hours before it's be euthanized. During the follow-up, we follow survival, boral flow, and blood samples for ammonia clearance, albumin INR, ICB, and necropsy finding and biopsy. Human endpoints are death of the pig or absence of blood flow in the graft, and grade 4 encephalopathy, uncontrolled bleeding, and reaching 48 hours post-transplantation. Our results. In vitro markers level, as we see here, von Willebrand brand factor before and after hepatocyte seeding, they are relatively similar in co-cultured group and the endo-only group, which means that hepatocytes didn't affect the viability of the endothelial cell. And for the albumin production, we have similarity in co-cultured and hep-only groups, which mean that endothelial cells didn't affect the hepatocytes. And for ammonia clearance, we have acceptable clearance level in the co-seeded groups. For the survival, we have a Kaplan-Meier curve here, which showing the survival rate at 24 hours was significantly higher in allograft compared to our bills, and this is not good for our bills, but the median survival times showed was 18 hours, which is the longest hour in all study in the world. Portal flow, we have sustained portal flow to our livers after portal vein declamping, as we see here in the pictures. Also, we assessed the patency of the vasculature of our biportal venogram after 1 hour of the in vivo perfusion with an intact vascular tree and no evidence of thrombosis. For the ICB and blood samples, our 24-hour survival bill demonstrated a low ammonia level similar to the allogenic group with no significant statistical difference between them. Also, the ICB measurements matched with the ammonia results. For albumin and INR, we see they are similar in the co-seeded and allogenic grafts with no significant difference. For the necropsy finding and biopsy, our bills revealed an increase in the volume of acetic fluid in the co-seeded group, and the post-transplantation histological examination of our bills demonstrated viable porcine hepatocyte and endothelial cells in the parenchymal and vascular compartment, respectively. Clinical relevance. In surgeries performed to treat end-stage hepatic alveolar echinococosis, known as ex vivo liver resection and autotransplantation, the native liver is removed completely for treatment. The duration of an hepatic phase in this operation is 104 minutes to 879 minutes. By comparing the anhepatic phase observed in this operation to our survival data, which was 18 hours obtained from the study, it's evident that our bills can effectively sustain the physical perfusion if utilized in the future clinical applications. Limitation of our study. The graft size. We have small graft size, which leads to small for size syndrome. This would explain the inability of the pigs to reach 48-hour survival endpoint. Also, portal hypertension was consistently observed in the experimental group, which showed increased volume of acetic fluid. This could be due to small for size syndrome and presence of hepatocytes within the graft, which increase the vascular resistance. Also, absence of cholangiocytes in our bills, which affects the development of functional biliary tree. Plans to manage limitations. The augmentation of the concentration of hepatocyte seeding is essential to facilitate and maintenance of our bills, thereby preventing the occurrence of small for size syndrome. Portal hypertension can be managed by creating a small porosystemic shunt, aiding cholangiocytes to our bills to create a tri-seeded bills. Conclusion, bioengineered liver offers promising prospects as a therapeutic alternative to tackle the shortage of donor organs for liver transplantation. Several obstacles must be overcome to achieve successful bioengineered liver transplantation. Also, there have been significant advancement in improving cell seeding and the graft functionality. The long-term survival following implantation of the orthotopic position remains limited. Co-seeding of bioengineered liver with primary hepatocytes and endothelial cells has demonstrated encouraging outcomes in terms of graft viability. This is our brilliant team, and thank you.
Be our guest in the next IASGO meeting next year, right? Okay. This is, we will be very honored to have you here next year, Professor Golemi. Thank you. We will present now. Questions now or later? Later, huh?
Okay.
Later.
Thank you.
Next. Our next speaker, yes. Okay.
Next speaker, one of the most loved chairpersons and distinguished staff in Jordan, Professor Abdul Hadi.
Okay. Assalamu alaikum.
Sclerosing cholangitis.
Mr. Chairman and dear colleagues, I want to congratulate my friend and brother, Professor Abdul Wahab, and his colleagues, teams, for this nice conference, which could be sustained in spite of what are happening all over the world, especially in our region. My talk will be a little bit different. I will not read a lecture or a review of literature. We have to think together how to challenge and to solve the problem of the patient with sclerosing cholangitis. I have a patient, Ruwaida, 43 years old, female, married, had children, previously healthy, accidentally discovered to have cholinesterase deficiency. She came on November 2016, deep jaundice and blurred of vision. Follow up in the medical department, they diagnosed as a Wilson disease. Through cut liver biopsy, mild induced hepatitis. Abdomen and pelvic CT scan showed that there is dilatation of the intrahepatic biliary tree with non-visualization of the confluence of the hepatic ducts. And there's a small lymph node measuring about 9 to 7 millimeter in the porta hepatis. So the decision what to do the next, MRCP or ERCP or metastatic workup, tumor marker, surgical intervention. And this is here ERCP. You look here, this is the gallbladder and this is the biliary tree, and it seems here the problem in the porta hepatis. The same picture. So the MRCP showed dilated intrahepatic bile ducts with non-visualization of the confluence, suggestive high-level obstructive jaundice, of course. Next step, what to do? ERCP, they restricted the level of the confluence with the biliary dilatation above the stricture. And as usual, our gastroenterologist colleague always hurry to put a stent. They are not discussing the case with the surgeons, so they put a plastic stent in the right common hepatic duct with the brush cytology. The brush cytology shows that bile duct blustering of stricture benign duct epithelium cells. There was no malignant cells. So we did a work up, all normal, apart from ALT, AST, bilirubin, and of course alkaline phosphatase, they are raised. The other investigation are normal. Also, we confirmed the cholinesterase, which is below the level. Here, IgG substances and tumor markers, all IgG 1, 2, 3, 4 within normal limits, as well as the tumor markers, carcinoid embryonic, carbohydrate, and alpha-fetoprotein. Virology and immunology, all within normal except the anti-nuclear antibodies, which they are positive. So, next step, what to do? We did a PET scan and revealed that imaging show evidence of an area of abnormal increased FDG uptake extending along the biliary tube from its intrahepatic part until the level of the ampulla of Vater. And also PET scan shows a photopenic defect in the right lobe of the liver. Upper GI endoscopy, hiatus herniatus esophagitis, hematological diseases, there's a thrombocytosis. So we decided to do a diagnostic laparoscopy, which converted to the laparotomy, and cholecystectomy done with Roux-en-Y hepatocogenomy above the obstruction. And this is to show some video finding before converting to the open surgery. So liver clear, there's no if the video should be work. We tried it before and it was work. Anyhow, we didn't find any pathology, so we convert an open one and cholecystomy. طيب شغله يا سيدي معلق. طيب خلينا تعال هنا انت اشتغل عليه وانا هتكلم عشان ما نضيع الوقت. Converted to an open laparotomy and we did cholecystectomy and Roux-en-Y hepatocogenostomy. خلاص اللي بعديه فيش داعي. Unfortunately, 1 year later, and maybe less. Okay. Next. Okay. عمل لي فول سكرين لو غلبه. الهيستوباثولوجي what we remove gallbladder, common bile duct, common hepatic duct, cystic duct, lymph node, all they are benign. There was no evidence of malignancy. all the removed specimens. Fibrous tissue, chronic inflammation, and gallbladder shows acute on top of chronic cholecystitis. Of course, postoperatively she improved. Her lumbar function is down, but maybe one year later, she complained of abdominal pain, elevation liver enzymes, and high alkaline phosphatase. And here MRCP shows again this picture. And this is the jejunum, which is the Roux-en-Y limp. Again, stricture in the area of anastomosis. Trial to do PTC, right side and left side. Hope this one video will work here. Yes, as you see, right PTC done, and it is dilated and the drain was inserted here. This is on right side. 12 days ago, we tried to do in the left side also. It is difficult from the first time to find a way in the left side. We couldn't go inside with difficulty. Then we inserted also a drain in the left side. So at the end, 2 drains were put in the right and in the left. Few months later, the left drain was dropped alone, and tube cholangiogram from the right side shows it is the anastomosis or the stent is patent. Again, 1 year later, she developed abdominal pain, itching, and high alkaline phosphatase. Here, her MRCP. Again showed structure at the same level. 1 year later, also, she started, the main complaint is itching and elevated alkaline phosphatase. So also MRCP done and showed the structure in the same area. And the Roux-en-Y jejunum here. So we decided to do revision surgery and to do what we can do. And we did intraoperative cholangiogram. This is the right system. We opened the anastomosis just below from the jejunum side. And we put a drain in the right duct. And we inject the contrast material. Look here, you will see that with difficulty. This is the right side. Some people they think that's the whole biliary tree. No, this is the right side. And look here. Here, there is structure here, then another biliary tree here. So this is the right side. Later, and here the left side. The difference between the left and the right, the left is hugely dilated biliary tree, saccular dilatation. And here the whole picture, the right and the left together. You see the left is enormously dilated, the right is dilated but not the same. So there was a 2 options, either to remove the left lobe and do right hepatojejunostomy, or just dilatation of the anastomosis and the closure. We chose the second option. Unfortunately, 6 months later, again, obstructive jaundice, alkaline phosphatase, itching, and this is her MRCP 6 months later. So again, we do PTC. We did PTC, and we could put a drain through the anastomosis, and this is from the right side. And we could dilate the anastomosis. So, and we put a drain inside it. This is, okay, showed that it's go down to the jejunum. This is the right side. The right side, we could solve the problem. Again, the right side, we lift the drain deep down to the jejunum in order not to skip outside and become jaundice again. The drain lift inside the anastomosis very deep here from outside. We tried to do left side PTC a few days later, and actually we failed to pass the stricture in the left side, and we couldn't put a drain in the left side. It is the left side very difficult to manage. A tube cholangiogram from the right side on July, we showed that the drain is inside, and we changed it to the biggest one, the bigger one. Here alkaline phosphatase decreased down, and some symptoms relieved. But unfortunately, still she has fluctuating level of alkaline phosphatase and impaired the quality of life until now, 6 years after the first surgery. So what's the plan? Repeated intervention radiological procedures as we see, or surgical intervention to do left hepatectomy with anastomosis, or to do revision, or consider liver transplantation if available and not available for the time being. What in my mind, I am thinking about hepatic jejunostomy over changeable transhepatic anastomosis in 2 stents, and change every from now and then as O shape by Saipel Icorian. We call them, this is the authors who did the first operations in this field. In conclusion, primary sclerosing cholangitis or cholangitis, a cholestatic liver disease characterized by fibrotic inflammatory damage of the biliary. It is a risk factor for cholangiocarcinoma. Indeed, the prevalence of carcinoma in patients with sclerosing cholangitis range from 7 to 13. The major challenges of cholangiocarcinoma in PSSC patients relate to lack of methods of early diagnosis and the absence of effective treatment. Early diagnosis of cholangiocarcinoma is delayed because its clinical presentation can mimic benign disease. Moreover, biliary and serum tests in diagnosed development cholangiocarcinoma and PCS are limiting, although the use of advanced cytology techniques for aneuploidy and chromosomal aberration are promising. As a result, current therapies do not extend survival, with the exception of the protocol liver transplantation, if available, to a selected group of patients. Thank you.
I think we have to have some comments on this case. Professor Golemi first. Can you comment on this case and the management of it?
So it's my congratulations on this case, very difficult case.
Yes.
Women start with narrowing of bile duct that is difficult to have a diagnosis. Brushing, in our experience, is not so effective in making diagnosis. The problem is if you start to perform surgery in this patient, you develop cholangitis, you develop stenosis, and so on. I think the definitive treatment, as you said, is the transplant. Otherwise, biliary drainage and therapy with ursodeoxycholic, some cortisone, and so on. So it's difficult to decide. The diagnosis is late, as he said, and maybe transplant is the solution of this case.
So you would like to proceed with liver transplantation?
Yeah.
Yes.
Thank you.
May Professor Muhammad Abdul Wahab, when is the proper time for this case regarding liver transplantation, I think she's a young girl.
Dr. Abdelhadi, thank you very much for your problematic case. But from the start, the first MRCP is mimic of cholangiocarcinoma. You feel that there is defect in the porta hepatis and the right and the left side dilated. At this time, you should think about cholangiocarcinoma or sclerosing cholangitis. If it is sclerosing cholangitis, by biopsy, as Professor Firdo said, it is liver transplant. Don't waste time. Thank you very much.
Thank you. I appreciate it.
I think pathological diagnosis here may be confusing also. Because we can't, in most cases of cholangiocarcinoma, prove that it is a carcinoma. So, considering the young age and the repeated obstructions, I think you should go to liver transplant.
May I respond, Chairman? May I respond? Yes, liver transplant, it is an option from the start in our mind, but it is not available. And until now, it is not available to find from the relatives and have small children. No other option. It is problem is not with to do the decision. The problem is to find the solution or transplant. Thank you.
Now, we have the great honor to introduce one of the most distinguished professors, not only at the national or international level, but globally, Professor Alfredo, and the surgery of cholangiocarcinoma between new system treatment and minimally invasive approach.
Thank you very much. Thank you to Mariana Honor for me to stay here. I have to thank particularly Mohammed Abdel-Wahab and Ibrahim for this fantastic meeting and fantastic organization. And next year, you will have another big congress in Cairo. So my great gratitude. So in few minutes, I should like to give you an overview of the current and the future perspective in the treatment of cholangiocarcinoma. This is our experience. As you can see here, intrahepatic cholangiocarcinoma had the most significant increase in these years. And up to now, nowadays, surgery remains the principal treatment of this disease. You can see resected patient has a 5-year survival of 38%. Unresected patients do not have survival at 5 years. But something is changing. In our experience, we treated until 10 years ago all the cases with open approach. Now we are slightly decreasing in this case, and we treated a slightly lower case, 70%, because we start a program of mini-invasive surgery, means laparoscopic and robotic surgery. But I want to stress that you can see that there is a little bit increasing of new systemic treatment. I want to spend some word about this. But what is the predictors of long-term survival in this patient, in cholangiocarcinoma? Multifocality, margins, lymph node metastasis. This is the most important prognostic factor. As you can see here, the survival after surgery, according to the last classification of American Joint Committee, you can see good survival for early case, T1A, T1B, survival around 50%, but not good survival for T2, T3, and T4 cases. Looking at this data, we go down and go deep in the observation of T2 tumors. That means multiple nodules. We make a study in our case, and we divide a single tumor with one satellite in the same segment, T2, with the T2 that is a single tumor with multifocal nodule in different segments. In our opinion, these two type of tumor is different. And then you can see here the survival in the patient with single nodules is the best. The survival in the patient with one satellite in the same segment is still good, the yellow line, but multifocal with nodule in different segment of the liver has bad survival. Bad survival, but as you can see, better than no treatment of this disease. What's about margins? Unlike liver metastasis, where the margin seems not so important in conditioning the prognosis, in cholangiocarcinoma, we must have good margins to have survival. This is a paper that shows that the margins of 1 centimeter give us better prognosis, a better survival. And unlike liver metastasis, as Guido Torsilli said in a very nice paper, vascular resection, R1 vascular and R1 parenchymal do not have a good result. So this, in cholangiocarcinoma, this aspect is completely different from liver metastasis, from colon cancer. So what have we do nowadays? We have to the treatment, the surgical treatment to obtain radical resection. And sometimes it's very challenging and demanding surgery, because often you need major hepatectomy or extended hepatectomy. You need vascular resection of adjacent organs, and all the times lymphadenectomy. In our country, I think also in your country, the diagnosis of this disease often is very late, because we do not have screening or do not have early diagnosis of this disease. What about vascular resection? Is indicated vascular resection in this disease? You can see a case of cholangiocarcinoma in low caudate lobe with complete infiltration of vena cava that needed the resection of vena cava, as you can see here. And in a multicentric study with Italian group of HPB, with Edoardo De Santibanes, with Antonio Pina, we clearly demonstrate that if you do vascular resection and you have radical resection, the survival is good, 48%, 44%. But if you have a vascular resection combined with other negative prognostic factor, I mean not radical resection or lymph node positive, the survival is not good. So vascular resection, yes, if you can obtain a real radical resection. Different question is the visceral resection. If you do resection of visceral organ, adrenal gland, diaphragm, or colon, right colon, and so on, these are T4 cases, and the survival is not good. Lymph node metastasis, few words. The lymph node positive is the strongest prognostic factor in this disease. And lymph node metastasis is very often, we observe, in about 40% of the patient. So we recommend in all cases to do lymphadenectomy, not only in large cholangiocarcinoma, but also in small cholangiocarcinoma. That is, you can see in the two groups, small on the left and large on the right, the survival is strictly conditioned by the lymph node. So a few words about the minimal approach, laparoscopy. We started this program with one objective, to do the same that open surgery. The Southampton Consensus Guideline, everybody knows, a few years ago, he gave the indication of colorectal metastasis, benign disease, hepatocellular carcinoma, living donor, but no mention of laparoscopic liver surgery for cholangiocarcinoma. So also in our experience, this is our experience of laparoscopic surgery, you can see that hepatocellular carcinoma is the first diagnosis in laparoscopy, and we start later with cholangiocarcinoma because we want to have the same oncological criteria. And up to now, we have 90% of lymphadenectomy and mini-invasive laparoscopic surgery in only 23% of the cases. as I said, we need the same criteria of radical surgery. We operated on only single tumor, stage T1A, T1B. We often have the necessity to do major hepatectomy, right hepatectomy or left hepatectomy. We perform a lymph node dissection in all the cases. You can see in the video that we use the same technique of the open surgery. And also the main survivor, the main number of lymph node retrieved is very high, 7. R0 resection in 80% of the cases, and the post-operative mortality is 0%. I go on to avoid to lose time, please. So, up to now, the data of the literature is not so big. So, up to now, we can say that mini-invasive surgery has better short-term outcome, less hospital stay, less blood loss, but we have similar long-term outcome. So, it's promising street to go on. But laparoscopy is very demanding for the surgeon, is fatiguing, is difficult to expose the field. So maybe in the next future, robotic surgery may overcome the limits of laparoscopic surgery. And other aspect very important, we can integrate with robotic surgery all the new technologies of 3D reconstruction and simulation of the tumor. We use intraoperative ultrasound. We can use indocyanine green to define the cut line and the bile duct. So in the next future, if we can use robotic surgery, maybe will be the standard treatment. The result is not so strong, but to now we can affirm that robotic surgery has the same oncological results like laparoscopy. And last topic. We define cholangiocarcinoma with an anatomical point of view, intrahepatic, perihilar, distal, and so on. But the knowledge that we have on oncological characteristics of cholangiocarcinoma let us to do that. It's time today to overcome the anatomical classification and to start a genetic classification of the tumor. The most important is FGFR2 gene fusion that demonstrates that the patient has two different kinds of survival if they have the fusion of this gene without the fusion. This is the result of the first protocol of pemigatinib. He treated the patient. The result is good, and the partial response stable disease is very high. So in the future, we have about 50% of cholangiocarcinoma that are potentially targetable with specific target therapy. Just a few words. We have 32 ongoing trials, no results. Also for immunotherapy, we have many trials, but the result is not definitive. So we start this journey just in these years. And just to show you a case that we have, this is a male with cholangiocarcinoma in the right lobe with metastasis in adrenal gland, you can see. We treated with Topaz 1, a protocol with zencitabine, cisplatin, and durvalumab. After 7 cycles, the tumor disappeared, so we operated the patient, and fortunately, we have completely response with total necrosis of the tumor. This is the only one case that we have. So the possibility is good, but now we have to take care that is just to start. So I conclude. New systemic treatment, target therapy, 50% of potential tumor, the intrahepatic cholangiocarcinoma. Immunotherapy, yes, but we have to underline that now the approved advanced metastasis is not a surgical patient. So the result of the treatment is a different cohort of the patient. Is not resected, not surgical patient. So the future, tomorrow, we have to change our surgical attitude. I don't know, I don't not have the answer. Maybe neoadjuvant preoperative and adjuvant postoperative with target therapy may be will have a good result with this treatment. But up to now, we just started the beginning, this journey, so I do not have a result. And I hope next year to have some result if this is a way that we have to follow. So thank you very much for your attention. Shukran.
For your elegant presentation and attacking a very difficult and problematic malignant tumor of the liver, intrahepatic cholangiocarcinoma, as we know. I ask you, if you have patient with intrahepatic cholangiocarcinoma without lymph node metastasis and another with lymph node metastasis, do you prefer preoperative chemotherapy neoadjuvant or go ahead for surgery? Because I write chapter in the multidisciplinary books for IASGO in these topics, and I found the role of immunotherapy or chemotherapy pre or post-operative up till now is not so good. Nowadays, if you have patient without metastasis and the patient with metastasis, what to do?
Oh, it's a difficult, good questions, difficult answer. As I said, we do not have enough data up to now to decide to go preoperative neoadjuvant therapy like in liver metastasis for colorectal cancer. So we prefer to go on surgery if we have good probability to reach R0 resection. Lymph node negative, you have a diagnosis of lymph node negative, but we demonstrate in a recent study of Mazzaferro that also in negative patient to perform a lymphadenectomy has better results, long-term survival. So up to now, we prefer to do post-operative adjuvant chemotherapy with gemcitabine and cisplatin, and when is possible with immunotherapy. But we have to wait for have stronger results. So up to now, we go on with the surgery.
Thank you very much.
Thank you.
Thank you very much. Do you recommend to do more major surgery in case of extending cholangiocarcinoma down, for example, Whipple operations to add to this management of these patients? And I want to stress the other point, which is that the biological aspect of the tumor is very important in the prognosis and the type of management. So what's your opinion about added major surgery as Whipple operations? In some
Major
cases,
with Whipple, you mean?
in some cases of extension of cholangiocarcinoma alongside with the common bile duct.
In Japanese results, up to now, if you do surgery in a good patient without any kind of risk, you can have good survival and acceptable complication. But the problem, as you said, is the biology of disease. We perform not much more than 8 to 10 resection of the liver and pancreatic resection, but only for papillomatosis of intrahepatic tumor of bile duct. So we have low, good biology of the disease, young person, young people, and the long diffusion. But for a very huge tumor that go from the liver to the pancreas, I think the result is not so good.
Professor, I will ask you a question, please.
Thank you, Professor Alfredo. Being we are in the era of more use of neoadjuvant therapy, either immuno or chemotherapy, so immunotherapy is promising, but most of this study is not in a randomized trial. So still it is a matter of racing, احنا في مرحلة سبق, for possibility of randomization between neoadjuvant immuno versus no, and then it is need for more randomized trial, but it is promising. Thank you.
I would like to comment also. If you have a small volume disease in both lobes of the liver, maybe with lymph nodes also, would you prefer to have a neoadjuvant therapy, or would you have to go upfront surgery?
Oh, we have a high.
Mind you, it's a small volume disease, but in both lobes.
Both in both lobes. We do not know enough the biology of the tumor at the beginning, so you have to decide how many risk factors you have. Risk factor of the patient, old patient or young patient, risk factor of lymph node, positive or negative. So if you have a low risk surgery and bilateral tumor, maybe adjuvant chemotherapy is adequate to select the patient. If they remain stable or respond to chemotherapy, you can go on to the surgery. If the patient do not remain stable at the progression of the tumor, surgery is not useful.
Yeah.
دكتور علي اتفضل.
My question about hilar cholangiocarcinoma, especially advanced one. Do you routinely remove caudate lobe? And how to determine interhepatic extent of hilar cholangiocarcinoma? Do you depend on MRI or you do frozen section? And lastly, what about anastomosis? You do multiple duct biliary enteric anastomosis or you do ductoplasty?
We remove all the time the caudate lobe, because if you have a tumor in the confluence, the caudate lobe is just attached to the confluence. We have many collateral bile duct segments that go just down in the caudate lobe. So we remove all the time the caudate lobe. And to evaluate the extension of the tumor is not so easy, because often we have to drain the patient before. So there is an open question to drain with PTC or to drain with endoscopy technique. If we have the stenosis of the hilum, we prefer PTC. And with PTC, we can define the extension. But first of all, CT and MRI before draining, because if you put the drainage, you cannot decide exactly the level of the stenosis. And then you have to planning the surgery before. Sometimes you can have a positive margin. You can go on with a few millimeters, because if you have a right hepatectomy, left hepatectomy, you do not have enough space. And you can enlarge a little bit. So in perihilar cholangiocarcinoma, portal vein embolization, extended hepatectomy, and correct evaluation of extension. Yes.
دكتور طارق.
Okay. It's a rapid question. You mentioned that for laparoscopy and open surgery, for you is the same. You mentioned you do the same with laparoscopy, right? Do you have a criteria for what cases to do laparoscopy and what cases to do open? In regards of the result and the survival?
This program started recently, 7 years ago. So we start with the principle to have the same oncological aspects to follow. So T1A, T1B, not a multiple tumor, not big tumor, so 5 centimeters, 6 centimeters, and to remove lymph nodes. So the oncological criteria we have to respect.
Okay. Thank you.
Thank you.
Thank you, our expert, Prof. Alfredo, and we now come to the Indian experience in intraluminal brachytherapy in locally advanced carcinoma of the gallbladder, Professor Niraji Rostouji.
Good morning,
Online?
sir. Can I hear you, sir?
Yes.
Good morning.
Good night.
I am thankful to the Egyptian chapter of IASGO as well as Professor Abdul Wahab and all the chairpersons of this session to present our data of intraluminal brachytherapy in unresectable carcinoma of the gallbladder, which present with the biliary obstruction. As we know, pancreaticobiliary cancers, gallbladder, pancreas, and cholangiocarcinoma usually have the similar presentation. But 80 to 90% of the pancreaticobiliary cancers in this part of gallbladder origin. And usually the patient presents with the nausea, vomiting, and anorexia and weight loss. And jaundice is very common in these patients. And this is the sign of the advanced disease. So, in most common hepatobiliary cancer, this is very high incidence in the Central European countries and in India. In India is very high in the northern and northeast part of the India, as well as very high incidence in the females versus the males. This is the Indian cancer registry data. 80% of the patients with advanced stage, they present in the unresectable, and the gallbladder usually fundus is attached to segment 5 and 4B and 5 of the liver. So infiltration is very, very common. And among the advanced disease, 50% present with the jaundice. And management of the gallbladder cancer is complex. Surgery definitely is the mainstay of the treatment, and in the advanced stage, it is not possible. And there is a patient is morbid because of the presentation of the jaundice, and then requires the palliative setting or biliary stenting and drainage. And usually these patients present with the jaundice because of the lymph node around the CBD, or maybe extension of the tumor from the gallbladder into the common bile duct, or maybe the pressure by the lymph node and the CBD. So when patients comes present with the jaundice, we have either resectable state, which is only 10% of the cases. Then the curative surgery is possible. And when comes in the unresectable stage, usually in the 85 to 90%. So we do either palliative surgery. Palliative surgery in the presence of the gallbladder jaundice is usually the very high mortality and poor survival. So non-surgical management and stenting is the treatment of choice. If patient present with the bismuth type 1 and type 2 disease, when is the common bile duct is blocked, or when the up to the hepatic duct, but the confluence of hepatic duct is patent, then usually the endoscopic biliary drainage gives the better results. But if patient has the type 3 block or type 4 block, then usually the percutaneous biliary drainage is required. And when there is a failed endoscopic biliary drainage, only then the percutaneous biliary drainage is required. So after the biliary drainage, we either put the plastic stent or expandable metallic stent. The problem with the plastic stent, because it is a narrow lumen and early block is there, and frequently it is dislodged. But the expandable metallic stent, it is blocked because it is fenestrated. It is blocked because of the tumor overgrowth or tumor ingrowth, or sometimes with the biliary sludge. But there is no dislodgement because it is incorporated in the wall of the CBD. And solution is there to avoid the tumor ingrowth and overgrowth. If we can offer the localized radiation therapy, that can growth strain, as well as it can increase the patency and decrease the chances of the block. And second option is restenting. So biliary blocks post drainage, this is the type 1 block. When the CBD block, when the type 2 block is usually the bismuth type 2, when the right or left hepatic duct is blocked, but the confluence is patent. Type 3 block, when it is going into the beyond the left and right hepatic duct, when it is the sub-channels block are there. So this is the usually protocol which we follow. Unresectable gallbladder cancer with biliary obstruction, we usually do the percutaneous or endoscopic biliary drainage. After the biliary drainage, we put the intraluminal iridium-192 radioactive source into biliary channel and then irradiate the area. After that, we exchange the biliary drainage tube into the self-expandable metallic stenting and subsequently we give the chemotherapy. So how we do it? Ultrasound and fluoroscopy guided percutaneous transhepatic puncture is done, and then the guide wire is passed. This is the guide wire is passed across through the block into the bile duct, and this guide wire goes up to the duodenum, and then do the percutaneous cholangiogram. And percutaneous cholangiogram will help us where is the site of the block. Like in this patient, the block is in the confluence as well as upper part of the common hepatic duct. So after the percutaneous cholangiogram, we do the balloon. This is the balloon. We do the balloon dilatation of the stricture. And after the stricture, we put the biliary drainage by the Mallicott catheter. Then we keep these patients because the very high serum bilirubin and very high jaundice. So there's a chances of the cholangitis is quite high. So what we do, we put the antibiotic for the 5 to 7 days in these patients. Then after when the patient is free from the cholangitis, then we put the 6 French. This is the usually 2 millimeter brachytherapy after loader catheter, and this is present passed into the 12 French tube. This is the 6 French catheter which is put into the 12 French tube, and then this is the dummy source. Dummy source is the metallic markers at 1 centimeter. So it helps us to know how much length of the biliary channel we have to treat. And usually treatment length is taken 2 centimeter margin on either side of the cholangiogram. So 2 centimeter healthy margin we treat on both the sides. So this is then we take the orthogonal radiograph film. This is the orthogonal radiograph film, and this is the 2 channels. This is the 1 channel in the right hepatic duct, other channel is the left hepatic duct, and this is small beads are the measurement dummy sources which helps in the measuring the length of the. So after the sources, we do the dose calculation. Usually the dose calculation is done by the isodose dose distribution, and usually the 10 gray dose at the 1 centimeter from the source. This is the center of the source, so we calculate the 1 centimeter on either side, and this is a Y-shaped dose distribution in which covers the confluence, right and left hepatic duct and the CBD. And this is the microselectron machine which is used, and this is the microselectron catheter which is put into the biliary drainage catheter. So this is the when there is a common hepatic duct block or CBD block, then the one of the tube is sufficient, and this is the isodose of the 10 gray which shows the 1 centimeter from the either side of the source is 2 centimeter diameter is being treated. If we have the confluence is blocked, then the 1 channel will be insufficient, then we put the 2 channels, one in the left hepatic duct, one in the right hepatic duct. Then it's the Y-shaped dose distribution of the radiation. If suppose the further channel is blocked beyond the right and left hepatic duct, then sometime it requires the 3 hours. Sometime there's a 3 tubes are there. One is the right channel, one is the left channel, which is the other distant channels as well. And this is the dose distribution, covering the whole of the confluence as well as part of the CBD and the channel beyond the right and left hepatic duct. So after doing the radiation therapy, we put the Gianchico stents, and this is the jet-shaped stent, which is the self-expandable stent. And depending on the size of the stricture, we put either the two segment stent or 3 segment stent or 4 segment, depending on this is X-ray radiograph shows the right and the left hepatic duct, which shows the two of the stents are in position. So this is the small study which we have done prospectively in our institute. We have treated 204 patients, all gallbladder, and treated between 1990 and 2020, and the And most of the tissue diagnosis are either taken by the FNAC or breast cytology. And we have treated these patients, 172 patients, with the intraluminal brachytherapy followed by stenting and chemotherapy, and 32 patients have not received any brachytherapy because at the time of the source, we don't have availability of the source. So these are the patients which were treated without brachytherapy but with stenting and the chemotherapy. So there is no difference in the demographic characteristics between the two groups. And this is the pattern of failure which I have found in all the patients. Definitely, gastric outlet obstruction was more common in the non-brachytherapy group, as well as it was stent block was also more common in the non-brachytherapy group. So this is the Kaplan-Meier survival curve, which have shown the median survival in these patients. This is the intraluminal brachytherapy group is 8 months versus which those are the patients which have not received any brachytherapy. Median survival is 5 months. And 1 year OS is 16% and 1 year OS of overall survival is 3%, which is a significant difference. If we see the stent patency, similar we have seen in the stent patency, median stent patency was 7 months in the brachytherapy group versus the 4 months in the non-brachytherapy group. Significant difference between the two, and 1 year stent patency is 11.6% versus 1 year stent patency is 0%. So definitely it has shown that putting of the brachytherapy decreases the growth within the stent and increases the stent patency. So when we have typed the multivariate analysis, intraluminal brachytherapy found to be factor of prognostic significance, which retained as independent prognostic factor for both stent patency and survival. So these are some of the studies which have shown if you put the stent, usually the median survival is 6 months. If you put a stent along with the brachytherapy, it increases from 7 to 14 months. So in various studies which have shown, it's a very large study from China which has shown the brachytherapy, which is they have 101 patients and stent patency median survival in these patients is 13 months. In our study, we have found in gallbladder usually 5 months without brachytherapy, 8 months with brachytherapy. So this has shown that intraluminal brachytherapy improves the stent patency as well as survival. So to improve further the survival, whether it has any role of the external beam radiation therapy in these advanced patients, except in some of the Italian study which have by Morganti, they have shown median survival with the external beam radiation therapy with brachytherapy is 21 months. But most of the studies, addition of the brachytherapy with the has not improved much of the survival difference. So various studies have shown if you add the stent with external brachytherapy, this is the 6 months versus 9 months. Basically, it has shown addition of the brachytherapy has improved the survival rather than the addition of the external beam radiation therapy. So just to conclude, I find to say that percutaneous biliary drainage is very safe procedure, very well tolerated and effective in palliation of jaundice, and brachytherapy appears to prolong the stent patency as well as it decreases the stent block because it delivers very high dose into the biliary channel and around the bile duct. And intraluminal brachytherapy also improves the survival. And when patient has the jaundice free for a longer time, it also improves the quality of life in patient. So, but it requires a randomized trial for a definite conclusion, but it is difficult to do. Thank you for your impatient hearing.
Thank you for this presentation, and to not stay online, any question for Professor Niraj?
Thank you, sir. Thank you.
Thank you. Thank you.
Do anybody want to have questions for Professor Raj? Yes, sir.
Yes, sir. Yes, sir.
Yes, sir.
Any questions, sir?
So I am Alfredo Guglielmi from Verona, Italy. My congratulations for this very nice presentation. I want to ask you your opinion. What do you think is important to combine brachytherapy with chemotherapy? Because gallbladder cancer is often a tumor that spread in the peritoneal space. So what is your opinion about this?
I think in the gallbladder cancer, few of the studies have shown that chemotherapy is useful, especially the gemcitabine, and some of the studies have shown the capecitabine. So I think the gemcitabine and capecitabine, they can be radiation sensitizer effect, and especially the cisplatin as well. So brachytherapy and the chemotherapy combination can help us in radiation sensitization effect in these patients. So may be useful.
Thank you.
Okay. Thank you, Professor Niraj. Thank you for this very informative talk. And we will now go to our next speaker.
Thank you very much for giving me the opportunity. I am really thankful to Professor Abdul Wahab sir, as well as the whole team of the Egyptian chapter of IASGO for giving this opportunity. Thank you very much, sir.
Thank you, Professor Niraj, for your informative talk and good answers to the questions. Thank you.
Thank you, sir.
You're welcome. We'll go to the next speaker, Professor Han from South Korea. Okay, the next one is
ستوري عندنا
موجودة. Professor Han?
Yes, thank you very much. I'm ready for the presentation.
You're welcome. The presentation for current updates of laparoscopic liver resection.
May I start sharing my slide? Is it okay to start?
Yes. Your talk, please.
Okay. Yes, I'm sorry. May I start now?
Yes.
I'm sorry because I've been the first speaker because but there's some overlap of some IASG meeting in Lyon. That's why in this session of Lyon IASG, I was the speaker and the chairman. That's why I had to speak late. So I hope your kind understanding. And it is a great honor for me to be a speaker in IASG Egyptian chapter 7th annual meeting. I'd like to express my sincere appreciation for Professor Wahab, Mohammed Ahab, for inviting me to this congress. Actually, Professor Mohammed Wahab will host this World Congress next year. So I think I am very looking forward to attend the World Congress of IASGO next year. Today, my topic is current update of lab resection. I have no conflict of interest. Actually, lab liver surgery is evolving from the open. Now the lab liver surgery is well propagated. Maybe in the future, robotic surgery will prevail. Today, because we want to know the current status, it is better to know the previous consensus meeting. So I speak about consensus meeting for lab liver resection. And the second, I speak about the progression, evolution of lab liver resection. And lastly, I speak about anatomy liver resection. First, consensus meeting. In the 2008, there was a very important meeting, consensus meeting for lab liver surgery, and I happen to I have a privilege to join this meeting. I can see that host of Jobuel and Daniel and me and many experts together in this meeting. This is very important because laparoscopic approach for lateral sectionality has become a standard practice. In the second International Consensus Conference, many lab liver surgeons expect that left hemihepatectomy become a standard procedure. But in the second consensus meeting, the major liver resection was considered as risky procedure because of its novelty. Only a minor liver resection is okay. So it's very similar to the first consensus meeting. I think still major liver resection is not a standard procedure. Actually, this is a still risky procedure associated with novelty. Anyway, even most of the lab liver surgeon, laparoscopic major hepatectomy is still a difficult operation. And after second consensus meeting, many colleagues tried to standardize this technique. That's why we make society, which is ILLS. It is International Lab Liver Society. The first congress was held in 2017 in Paris, and at the time there's 7 members become executive member. And in 2019, there was a second meeting. Goa Kawashi was the Professor Minoru Tanabe, who was the co-chair of this meeting. And at the time, this is executive body as well. And the third Congress was held in New York, was planned to held, but because of COVID, this Congress was done by only online virtual meeting. Anyway, in this year, in September, there was a first ILLS meeting, which was hosted by the Luca Dreghetti and Robert Tracy and Mohammad Abu Hilal. I will show later, but 2025 ILLS will be held in Seoul, Korea. Then we will see the stepwise progress of lab liver dissection. Still, there is some debate on the tumor located in the right and posterior superior area, and the tumor close to major vessel and large tumor. This is still some debate. Actually, posterior located right side and the central located tumor is a very difficult operation. In our institution, Seoul National University Bundang Hospital, we try to develop the technique by stepwise approach. First, a very simple procedure to more complicated procedure. As you know, a right prosectomy, segment 6 and 7, is a very difficult operation by laparoscopy. And I have a privilege to report on this laparoscopic right prosectomy in 2006, about 17 years ago. After report in 2006, 9 years later, we have some cases of right post-hysterectomy. That is why we have compared right post-hysterectomy and laparoscopy versus open surgery. This is the comparison of laparoscopy versus open surgery after right post-hysterectomy in hepatocellular carcinoma. Left side is overall survival, and right side is disease-free survival. There is no difference in the laparoscopy versus open liver dissection. However, posterior superior region is segment 4B and segment 7 and 8. This posterior superior region is also a difficult operation. We can say this segment on favorable location compared to anterolateral segment, this is a favorable location. Yes, this is a difficult operation by laparoscopy. In 2008, about 15 years ago, we had a report on the feasibility.
Ciao, Sale Cremarchi, ciao, si Sale adesso. Izvini, morate te zovem, idem ja u salu, poslije ne znam šta ćete naći. Jutro...
Can I continue? Can I continue? Okay.
Yes,
Okay.
yes.
Yes. So yes, in the 2008, you have reported that the outcome of laparal liver resection for tumor located in posterior segment is comparable to tumor located in anterolateral segment. It is 2008. After 8 years later, we have more cases of posterior segment. At the time, we have compared posterior segment versus anterolateral segment by case match analysis. If you look at this comparison between the posterior and anterolateral, posterior is thick line, anterolateral is a dotted line. Overall survival is similar between the two groups, and disease-free survival is similar. Yes, posterior segment is difficult operation, but even if it is performed in very selected cases, the survival outcome is similar between posterior versus anterolateral segment. I'd like to compare the liver dissection by the sports. In the sports, the ski, I like skiing. So I don't know, in Egypt, there are few people who are enjoying the ski, but in Korea, many people are enjoying the ski in the winter. And if you go to enjoy skiing, there's some sign of the caution, the dangerous slope and the easy slope, moderate slope. I think the posterior superior is a very steep slope, and the anterolateral is the easy slope. So if you are expert in lap liver dissection, you can enjoy the difficult operation. If you're a starter of the lap liver dissection, you can do anterolateral segment as well. Anyway, segment 7, segment 8 is very difficult, but we try to overcome the anatomy section of segment 7 and segment 8, and also central located tumor is regarded as a difficult operation because in central located tumor there's a high possibility of the major vessel injury and bleeding. We have very close. In 2013, about 10 years ago, we have analyzed data of this surgery for central located tumor, which is very close to hilum or major hepatic vein and inferior vena cava. At the time, in this report, this is only 13 patients. The patient is usually mostly HCC patient, and the tumor is very close to major hepatic vein and inferior vena cava. And the operation performed the right post-sectionectomy and central bisectionectomy, right and left hemihepatectomy, including 4 caudate lobe dissection. Actually, for central located tumor, the operation performed is very complicated procedure. Even in this complicated procedure, when you compare the open versus laparoscopy, overall survival is similar, and disease-free survival is similar, although there's a tendency of better disease-free survival in laparoscopy. Anyway, In well-selected cases for central locate tumor, the outcome is encouraging. And recently, we have analyzed data long-term outcome for this surgery for central locate tumor. This is the graph of overall and disease-free survival. If you see the left side overall survival, the blue line is laparoscopy and green line is open surgery. There is no difference. Also, in the disease-free survival, there is no difference, but the tendency of better survival in laparoscopy. So even in central locate tumor, if well performed in selected cases, outcome of liver surgery is encouraging. Total whole-day lobectomy is possible, and we have reported on the isolated whole-day lobe resection in 21 patients, HCC patients. Anyway, another debate may be the large hepatocellular carcinoma. So there's some debate in the applying for lateral liver resection for large hepatocellular carcinoma. That's why we have analyzed data of our cases. After propen score matching, we have 70 cases of liver resection, and another 70 cases of open liver resection we have compared. This is the before propen score matching. The lower side is after propen score matching. You can see there is no difference in survival between laparoscopy and open surgery, even in the large hepatocellular carcinoma. So anyway, now we try to overcome the limitation of liver surgery. So my previous international fellow is from Italy, from Roberto Troisi's group. Dr. Gianno Cassese reported a review article leaping the boundary of this surgery. Anyway, there's some limitation in the central locate tumor or multiple HCC, but we try to overcome this surgery in the difficult operation. Let's say I speak about anatomy liver resection. So recently, for laparoscopy, anatomy resection, importance of laparoscopy resection is anatomy resection is becoming more evident. I will speak about the Gleason and pedicle approach and background for anatomy resection and about this technique. The patient with HCC has associated poor liver function, chronic liver disease. So it is better to preserve volume as much as possible, and the resection of only liver segment is better for the patients. It should be like a cake cutting, and it is better to perform segment by anatomy. Gleasonian approach is very useful by total S4 section by using Gleasonian pedicle approach. So by using Gleasonian pedicle approach, vision of tumor depending on liver volume function. So any anatomy section can be possible. Recently, this Gleason approach is becoming more and more very evident. That's why there's some expert meeting. They have reported on Gleason and pedicle approach, and precise technique is very necessary. After liver resection, there's often remnant liver ischemia. So remnant liver ischemia, you have hypothesized the very lethal or is a factor for the poor survival in the patient with hepatocellular carcinoma. That is why we have analyzed data of association of remnant liver ischemia with survival. We have analyzed many factors for the survival, including stage, previous stage E, childhood class, transfusion, anatomic, non-anatomic section, satellite nodule, and vascular invasion. Most of this factor are associated with prognosis. But when you analyze this whole factor by multivariate analysis, the only factor for both overall survival and disease-free survival is remnant liver ischemia. So remnant liver ischemia is very important factor in both overall and disease-free survival. That is why we have divided the patient group in minimal remnant liver ischemia and severe ischemia. So if you look at overall survival, if the patient has severe remnant liver ischemia, the survival is worse and disease-free survival is also worse. That's why when we operate on the liver resection, we have to minimize remnant liver ischemia as much as possible. That's why meticulous parenchymal dissection is necessary for the patient. This is a pencil and this is lead, very meticulous. So please, liver resection is better to be meticulous as possible. Sometimes anatomy section is minimizing remnant liver ischemia compared to tumorectomy. I'd like to show one total caudate lobectomy, but it is 3 minutes. Okay. Sorry. It's in okay. I'm sorry. Anyway, our group is very much interested in the anatomy section. That's why we have reported many anatomy section. Last year, we have performed 2,000 cases of liver section. I think now any difficult operation can be possible, and also because we have reported all area anatomy section, we are privileged to have a public-sized collaterals of liver resection. So if you're interested in the anatomy liver resection, you can refer to this atlas. How about future? I think now robot-assisted surgery will prevail more because young surgeon, because of the very long learning curve, robot-assisted is a very attractive option, and because this may have some advantage of suturing, so I think robot surgery will prevail in the future. Before finish my speech, I'd like to speak about the ILS 2025. This meeting will be held in Seoul 2 years later in June 24 to 27th. The meeting place, conference venue is COEX. The COEX is the very convenient place for the dining and shopping and amusement. So I welcome all of you to ILS 2025. Although it will be held in World Congress of 2024 in Egypt by Professor Wahab. Thank you very much. I'd like to finish my speech by showing our respected Professor Gitakis. Thank you very much.
Thank you for this nice presentation, and we also welcome you to Cairo.
Thank you very much.
Also, not to stay. Thank you. Thank you, Professor Han. Thank you.
Thank you. Thank you very much.
Please, Professor Han, a question.
Hello, Han.
Professor Han.
Hello.
Yes, thank you very much.
Yes, hello, my friend.
Abdul Wahab, Professor Abdul Wahab. Yeah.
I'm Tarek.
Oh, Tarek, my friend.
Hello,
Tarek Ibrahim.
how are you?
Tarek Ibrahim, yeah. Good to see you.
Yeah, good to see you. Thank you. Thank you for your very elegant presentation. You said
Thank you very much.
Yeah, well, you said that for laparoscopic surgery, you have no, you can do all whatever you can do with the liver, right? But what is your limitation? Is your limitation like the open surgery, or you have no limitation for the laparoscopic liver resection?
Yes, Professor Tariq Ibrahim, it's a very good question. In my institution, we are doing about 70 cases by laparoscopy. Actually, still the multiple HCC and also large HCC may be a contraindication. But the most difficult operation is clasking tumor. So we have reported on the several cases of clasking tumor, but still, for oncology point of view, I think still clasking tumor is a contraindication for laparoscopy. But still, if a very large HCC, very multiple HCC, very cirrhotic, still it is a contraindication. Thank you very much for your excellent question.
Thank you.
We have to close this.
Thank you very much.
Please, any question for Professor Han? Yes.
Han, nice to meet you. I'm Alfredo from Verona, Italy.
Yes. Thank you very much for the invitation. I missed your lecture, but I saw you speaking. Thank you very much, Alfredo.
Congratulations for your beautiful experience presentation. I want a short question. How do you consider the learning curve in young generation of surgeons? This is a big problem in our country. How to improve learning curve to make safe surgery also for young surgeons?
Yes, Alfredo, President of IASGO. It's a good question. Actually, as I said, robotic assisted liver surgery becoming more popular because lab liver surgery still has a high steep learning curve, so it takes a very long time to learn. So for the aged person like me, so we can do lab liver surgery, but for the young surgeon, it is very difficult to have a good expertise in lab liver resection. That's why many young surgeons is trying to do robot liver surgery. I think in your question, more and more young surgeons may do robot surgery. Although some disadvantage of robot surgery is expensive, but the recent articles say that robot surgery and lab liver surgery has a similar, better outcome. So, and also complex surgery like classic tumor, there's an advantage of robot surgery. That's why in the future, young surgeons may use robot surgery more and more. Thank you very much, the President of ISO, Alfred.
Another question from Professor Abdul Wahab.
Yes, Professor Han.
Professor Wahab, thank you very much for the invitation.
Thank you very much, and we miss you this chapter in Cairo. But what about it?
Sorry.
Yes. What about the laparoscopic liver resection in cirrhotic liver? As we know, in our locality, 90% of HC on top of cirrhosis.
Professor Wahab, thank you very much for your excellent question. Yes, it is still debate, but laparoscopy has some advantage over open surgery for cirrhotic patient because by laparoscopy, the cutting of the collateral flow is minimized. In our report, the incidence of ascites is less in bilaparoscopy. So anyway, for cirrhotic patients, still about type B, there are some papers that we can apply laparoscopic surgery. So anyway, for cirrhotic patients, still there's a debate, but we have to think there's some advantage by laparoscopy by minimizing cutting or lateral flow. Thank you very much for your excellent question, Professor Wahab.
Thank you. Thank you. Thank you, Prof. Han. We have
Thank you very much.
We have to delay. Thank you. We have to delay the other talks for after. Prof. Islam Ayub, central hepatectomy changing the concept.
Bismillahirrahmanirrahim. Dear professors and my colleagues, I'd like to thank all IASGO organizers. Many thanks for my dear professors. I'd like to present central hepatic lesions from trisectionectomy to anatomical central resection. Resection of hepatic malignancy has been facilitated greatly by an understanding of hepatic segmental anatomy. Moreover, major resection for hepatic lesions requires consideration of the volume and function of the remaining future liver remnant. Traditionally, patients with centrally located liver tumors are managed with extended hepatic resection, including right or left trisectionectomy and right or left formal hepatectomy. What's the concept? The concept is central hepatectomy, changing the concept. And why we change it? The concept is to do extended hepatectomy for central hepatic focal lesions. We change the concept for the sake of this young adult male patient. Male, 26 years old, with ulcerative colitis, presented with jaundice and abdominal pain 1 month ago. He was found to have hepatic focal lesion measuring 6 by 5 centimeters, occupying segment 4 and 5 on CT. Patient underwent multiple trials of biliary drainage before surgery and decreasing bilirubin level. The second, we change the concept for based on preoperative planning using 3D simulation imaging of the preoperative contrast enhanced triphasic CT. The decision in this case is extended right hepatectomy. The expected remaining liver volume was 28%. Note the centrally located lesion and we take a biopsy before surgery and not conclusive. Biliary drainage was done on the right and left sectors. And the planning to do extended right hepatectomy. This is a 3D simulation study. Now we use in all cases in National Liver Institute, Menifee University. This is the section before, and this is the hilar dissection, right hepatic artery, common bile duct, and infiltrated right portal vein. And this is the parenchymal transection to do extended right hepatectomy with caudate lobectomy in this case for the expected cholangiocarcinoma. Biliary enteric anastomosis on the remaining liver was done. and this is the specimen interoperative. Post-operative length of hospital stay was 10 days, and unfortunately, the patient died post-hepatectomy liver failure. The main limitation of extended hepatic resection has been the high rate of post-hepatectomy liver failure. However, recent systematic reviews have shown that central hepatectomy is an interesting parenchymal sparing alternative to right or left trisectionectomy, and this is the main concept. Central resection is defined as en-bloc resection of Kunuz's segment 4A, 4B, 5, and 8. It's also in the literature mesohepatectomy, central bisectionectomy, and central bisegmentectomy, and central hepatic resection. Central hepatectomy has been performed for centrally located liver tumors, including HC, colorectal, and cholangiocarcinoma. Central resection achieves equivalent oncological result to extended hepatectomy with preserving greater future liver remnant in selected patients. Central resection, good oncological result, and parenchymal sparing. Technical aspect of central hepatectomy is an uncommon surgical technique that is an option for resection of central located tumors. However, central hepatectomy is technically challenging as it requires dissection in proximity in critical hepatic vessels and more extensive dissection planes. This is two techniques, classic techniques and the double liver hanging technique. We do the classic technique, and this is the double liver hanging maneuver. The outcome of central hepatectomy versus extended hepatectomy, a systematic review and meta-analysis, it preserves liver parenchyma and is associated with an overall lower morbidity, and including reduced post-hepatectomy liver failure and shorter overall hospital stay compared with extended hepatectomy. Male patient, 28 years old, with accidentally discovered hepatic focal lesion 5x5 occupying segment 8 and 4 on CT. Based on preoperative planning using a 3D simulation study, our decision was central resection. This is a normal liver. Dissection planes between left lateral and segment 4 and extraglussonian approach to segment 4B. Excision of segment 4B. Intraoperative finding, the lesion is infiltrating the common hepatic duct and right and left hepatic duct. This is the middle hepatic vein. And after excision of the lesion, bilioenteric anastomosis was done on 3 ducts. And this is the final after parenchymal dissection. Post-operative stay 4 days. There was no post-operative
إننا اليوم وقد اجتمعنا نجد في لقائنا
8 by 7 centimeters occupying segment 4 on CT. Child A, male 6. Also, based on the preoperative planning techniques which change our concept, central hepatectomy or extending left hepatectomy. With extended hepatectomy, the expected remaining liver volume was 30%, while with central resection, the expecting remaining volume was 87%. This is the 3D simulation. Central resection was planned. the mass occupying segment 4A, and this is the line of transection between posterior sector and segment 8 and 5. And this is the starting the parenchymal dissection between left lateral sector and posterior section after ligation of the pedicles. This is the hilar dissection, lowering of the hilar plate. Segment 4 pedicle encircling and division. Anterior sector pedicle enterohepatic extraglucinian encircling. Intraoperative after resection. And this is the central mass.
The central resection, the left lateral segment. The posterior, right posterior segment, sector.
After resection.
The common bile duct. Left duct, right posterior duct.
Left side and the right side.
The right hepatic artery and the right posterior.
Post-operative length of hospital stay was 5 days. There was no post-operative complication, pathology HCC with free surgical margins. Central resection achieves equivalent oncological results to extended hepatectomy while preserving greater future liver remnant in selected patients. Performing pre-operative vascular and biliary anatomical assessment is essential for better decision making and better outcomes. And thank you.
Thank you, Professor Islam. And we have to delay the other session for Professor Muhammad Abdul Wahab to can learn listening from 25 years of surgical management adequately. يعني يا ريت بعد الصلاة as possible as you can. الساعة 12 وتلت يا ريت نبتدي الجلسة. الساعة 12 وتلت as we can. بسم الله الرحمن الرحيم. ما أحلى التعليم، وما أحلى أن نتعلم، وما أحلى أن يكون المعلم ذو experience up to 25 or more years with Professor Dr. Muhammad Abdul Wahab, lessons learned from 25 years of surgical management.
هنا لا مش دي كولانجو كارسينوم.
روح هات حاجه ان ابوك عيان وانت مسافر معاه. وبالفعل سافر 6 شهور وجاب عقد جراحه. هم عايزين ولغايه دلوقتي ما جابش. هو يعني محمد ابن الفضل ده خلاص بدفع له بتاع عشان دولار بتدفع انا ما عادش انا مش عارف ما عادش تدفع خلوهم مسكين. انا بقول لك هو الولد يعني الحقيقه بعد 6 شهور قلب قدر ياخد نيابه جراحه. لا في النهايه طالما
خلاص يا عم خلاص بقى عشان بس الناس ما تتضايقش. Good afternoon, my colleague and my professor. I will Thank you very much for all of attendees this symposium or chapter, especially the big professor from abroad and Alfredo who present today very nice and intelligent presentation and subject. Thank you very much for you. Today I will present our experience in Mansoura about a problem in biliary system, what's called cholangiocarcinoma or Klatskin tumor. I will discuss in simple way for the young doctors attending this meeting. As we know, it is a malignant tumor arising from the epithelium of the biliary system. It's the second most common or most frequent malignant tumor of the liver after hepatocellular carcinoma. Grow slowly and infiltrate the surrounding structure such as liver, parenchyma, intrahepatic duct, and hepatic pedicle. We published this paper 2007 for epidemiology of hilar carcinoma in Egypt, single center. We conclude that the number of the newly diagnosed cases increased annually. Common in males rural residents, bilharziasis in the past, chronic typhoid infection, and gallstone can be the risk factor. Also, we found heavy metal is a risk factor for development of cholangiocarcinoma. The Nile Delta region is significantly associated with high serum level of heavy metal, especially cadmium and lead. Epidemiological and risk factor, age presentation, very common in East countries due to parasitic infestation. What types of cholangiocarcinoma? As we know, intrahepatic type, distal type, and central type. Very important, how to diagnose cholangiocarcinoma, central cholangiocarcinoma. Usually it is associated with painless jaundice from the start, followed by weight loss, and the pain are the most common symptoms. When you have a patient with jaundice, I think, first of all, you should do for him ultrasound from the start to find if there is intrahepatic biliary radical or no. Sometimes early jaundice, you can find the biliary system not dilated. So repeat the ultrasound week after. If you have dilated intrahepatic radical and the common bile duct normal, it is usually Klatskin tumor. أو benign stricture, very rare, أو stone impacted at the carina, very, very rare. Second, go to non-invasive, safe procedure investigation, MRCP, not ERCP. MRCP provides non-invasive cholangiopancreatography. There is no difference between MRCP and ERCP. Better than ERCP for recognizing the proximal extent of the tumors. CT, if you have a patient with jaundice, ultrasound shows intrahepatic biliary radical, MRCP, possibly diagnosis Klatskin tumor. What's the role of CT? Determines the focal lesion of biliary tract up to 70%. Vascular invasion, very important thing to determine the resectability of the tumor. Lymph nodes and liver metastasis and ascites. In this case, it is up the line of treatment. What about ERCP? Invasive technique, direct visualization of the biliary tree like MRCP. After introduction of MRCP, the indication of ERCP for diagnosis has decreased and delimit its role in diagnosis. BTC invasive technique after the era of MRCP, it is good. Now in the role for biliary drainage, its role for biliary drainage and associated with cholangitis and the biliary leak and biliary peritonitis. BCT is reliable for diagnosis 60% of cases, but I think no role for PET scan to diagnose or to investigate. Cholangioscopy, peroral or percutaneous with biopsy has important role in differentiate diagnosis of biliary stenosis at the carina. Angiography, very important. In the past, it is invasive, but now by CT angiography to evaluate the right duct encasing the portal tract, portal vein right or left, hepatic artery right or left. In Mansoura Center, up till now, we faced 283 patients from 1995 up to 2018. 20 patients excluded, irresectable. Resectability and the prognostic factor after resection of hilar cholangiocarcinoma. This paper published 2006. We found from this study that aggressive surgical resection to obtain curative resection with preoperative serum bilirubin below 10 milligram, and HCV infection negative, especially in non-cirrhotic liver, may be a better prognostic in hilar cholangiocarcinoma. What is the criteria of irresectability or unresectable? If you have a patient with Klatskin tumor, bad general condition, advanced liver cirrhosis, bilateral involvement of the bile duct up to secondary branches, involvement of the biliary tract of one side, biliary tract in one side, and the vascular encasement of the other side, peritoneal metastasis and liver metastasis. This database of our cases, pain, weight loss, HCV infection, HB, liver cirrhosis. Unfortunately, we have a considerable number of patients with cirrhosis, and I will discuss at the end. Preoperative drainage, very important point, and it will be discussed. What is the treatment of Klatskin tumor? Preoperative biliary drainage, the question mark. Surgical treatment, resectable, biliary resection and hepatic resection, biliary resection and the caudate lobe resection. A resectable case, what to do? Biliary bypass or intraoperative biliary stent. Non-surgical endoscopic stent, interventional radiology BTD or BTC, liver transplant, adjuvant new therapy, and palliative therapy. A very important point about preoperative biliary drainage, to do or not, whether by ERCP or BTC. What disadvantage? Look here, you can have many patients after exploration with preoperative biliary drainage. You find common the gallbladder with biocele, pus coming from the biliary system. And here, stent inside, you find a pus coming from the cut surface after resection. So you should be careful when you decide to drain the biliary system in cleft skin tumor. Why? You have a tumor in the carina by ERCP, it is difficult to go up in most of cases. So you introduce a dye and leave the patient. Tomorrow you lost your patient by septicemia and shock, whatever. So go through surgical resection طالما في high bilirubin not risk factor, but albumin, creatinine, INR is good. Go to resection without any problem. Specimen, you have multiple liver abscess after BTC, ERCP or BTC. A paper very interesting. Preoperative outcome after major liver resection in jaundiced patient with proximal bile duct cancer without preoperative biliary drainage. We published this paper 2015. We found that major resection without preoperative biliary drainage, leaving a remnant of more than 50% is safe in jaundiced patient. However, transfusion requirement and morbidity are higher in jaundiced patient than in non-jaundiced patient. Our surgical strategy in Mansoura start by extrahepatic duct resection, skeletonization of the portal vein, hepatic artery, lymphadenectomy with different types of hepatic resection in the treatment of choice. We start with skeletonization of the pedicle, lymphadenectomy up to supraduodenal and from the celiac trunk. Resection as the same. The choice of operative procedure. You remove the tumor, carinal resection only, or left hepatectomy, or right hepatectomy with caudate lobe tumor. What is the indication? Depend on preoperative evaluation, liver cirrhosis, lobar atrophy, and the intraoperative finding. So it is difficult to decide when to explore a patient with cleft skin tumor to do local resection or go to the right or go to the left. This is starting by lymphadenectomy, extrahepatic bile duct resection from the start, and skeletonization of the artery and the portal vein. Example, left hepatectomy with a caudate lobe resection, starting caudate lobe resection after removal of the left lobe and cut surface of the right lobe with left hepatic vein, portal vein, right artery, and IVC. And in this picture, you show the middle hepatic vein preserved, IVC, right hepatic artery, and the portal vein. Type of resection, whether localized, left hepatectomy, right hepatectomy, caudate lobe resection. In our series, resection of the extrahepatic bile duct only 20%. Major hepatectomy, left hepatectomy 46%, right hepatectomy 22%. What's the indication of left hepatectomy? Atrophy of the right lobe, invasion of the left portal vein, tumor involvement of the left duct up to the liver parenchyma. Example of lobar atrophy and invasion or encasement of the left portal vein, Here you should show that, guarantees that the right duct is patent and you have a considerable length of right duct to get safety margin and suitable for hepatojejunostomy. An example of right hepatectomy, we have a lot of patients, right hepatojejunostomy, operative cholangiography, right hepatojejunostomy, right hepatectomy for cholangiocarcinoma, vascular infiltration of the right side, tumor involvement of the right side, and confluent tumor. An example of many cases, you show localize the resection, just resect the carina and do right and left hepatojejunostomy. Confluent tumor in cirrhotic liver. So there is a fear for hepatic cell failure if you did major resection. Confluent tumor in borderline liver function. Upper third tumor, basement 1. Positive lymph nodes, so the prognosis is very bad after major resection. Post-operative morbidity, we have a lot of infective complication, bile leak, hepatic failure, and renal failure. What about mortality? In our series, 15 patients from 263, 5.7%. Hepatic failure, 10 patients. Infective complication through patient and cardiopulmonary 2 patients. What about recurrence of central cholangiocarcinoma after surgery? Very important. After long follow-up, we have 98 patients presented with recurrence, 37%. Site of recurrence, whether hepatic or outside or local recurrence. Treatment of local recurrence at the site of hepatojejunostomy is percutaneous transhepatic drainage in 20 cases, dilatation of the obstructive anastomosis, 5 cases, resurgery of recurrent cholangiocarcinoma in 8 cases. And this example, very interesting, this patient at 26 years age presented with central cholangiocarcinoma, married and have no offspring. We did for her left hepatectomy and right hepatojejunostomy. Unfortunately, after 32 months, she, during follow-up, come our center, pregnant, 5 months, and jaundice. What to do? Problem. We, طبعا, percutaneous transhepatic, very dangerous for precious baby, fetus. So we did for her re-exploration and the re-resection at the hepatotomy, and we did for her another hepatojejunostomy. The patient completed the pregnancy and get very beautiful child or baby and massive metastasis at 56 months and died. Another very rapid, this from the annals of surgery, our last point, hilar cholangiocarcinoma in cirrhotic liver. Very important and very problematic. Patient with concomitant liver cirrhosis and hilar cholangiocarcinoma should not be precluded from surgical resection and should be considered for resection at high volume center with expertise available to manage liver cirrhosis. The incidence of early postoperative liver cell failure was significantly higher in the cirrhotic group. An example of female patient presented with advanced cirrhosis, MRCP showing Klatskin tumor and CT dilated intrahepatic biliary radical in the left lobe. The decision was to remove the left lobe and the bile duct, and this the cut surface, and this right hepatic genostomy, and this basement of the left lobe in cirrhotic liver cholangiocarcinoma. This our experience. What about lessons from this experience? Now in Egypt, Klatskin tumor is not uncommon as in the past. Patient with jaundice, as I said, ultrasonography is the first diagnostic method, followed by MRCP. Preoperative biliary drainage, if indicated, not ERCP, but BTD. Clear histological surgical margin, either through minor resection or major hepatic resection, was associated with improved survival. Negative lymph nodes and differentiated tumor together in non-cirrhotic liver improve post-operative survival and produce satisfactory outcome. Thank you very much for your attention.
Thank you, Professor. Questions? Anybody needs to question this? Yes.
اديله المايك. مقالة محاضرة ظرف.
Thank you, Professor Abdul Wahab, for this highly illustrated talk. Please, as mentioned in your talk, there is increased incidence. It is actual increase or due to more awareness and more diagnosis, or both, because you are always alarming us from the environmental pollution, especially kitchener pollution. Thank you.
This is a question or comment? Comment.
Dr. Abu Wahab, thank you for the illustrative presentation. Regarding the spreading of the cholangiocarcinoma, so what is the recommendation for early detection, for example? Because some cases not presented with jaundice. Usually jaundice is a sign.
Do you know that the upper common bile duct is 2 to 3 millimeter?
Yes.
So tumor half centimeter or 2 millimeter size will obstruct the carrier. Before obstruction, what you can investigate?
Yes.
Why you investigate? Nothing.
Because in HCC we used to do ultrasound.
HCC it's a different pathology. In cirrhotic liver, you should investigate the patient 3 monthly by ultrasound to detect early HCC, even 2 or 3 centimeters. Here, it is a problem. Without jaundice, otherwise we can do MRCP for all people in Egypt.
Yeah, because there's many people discovered with multiple cholangiocarcinoma, central.
This central intrahepatic cholangiocarcinoma differ from central. Central is small tumor, the carina. So it is difficult.
Thank you.
شكرا محاضرة. بالنسبة localized resection, you remove segment 1?
No, you remove the carina.
Because we know that this
And
is
do
a site of
bilateral
recurrence.
hepatogenostry.
And you didn't try to improve the recurrence by removing segment 1? Because
Yes.
there is a direct
You
communication.
mean segment 1?
Yeah.
It is mandatory to remove segment 1.
In localized.
As Professor Rahul said to us in her talk, caudate lobe, the biliary system of caudate lobe drained directly to the carina, and sometimes left or right. So in localized resection, you should remove caudate 1. Right or left resection, you should remove caudate lobe. And we have study and the different publication that patient with caudate lobe resection plus major hepatectomy, the prognosis is good, significantly survival is good, and the recurrence is low than patient without removal of the caudate lobe.
So in localized resection, we also remove segment 1. Okay, thank you.
Professor Game.
Oh, thank you for this excellent presentation, great experience. I should like to know, in Klatskin tumor has a very high morbidity and mortality. Liver cirrhosis usually is a contraindication surgery. You present a paper that said it is possible to perform surgery in liver cirrhosis, but what kind of surgery you recommend in Klatskin tumor with liver cirrhosis?
I recommend localized resection if there is no extension up to the parenchyma. Most of the cases, we remove the carina to avoid post-operative liver surgery.
Dr. Muhammad, thank you for presentation. And ask about the future of transplant of cholangiocarcinoma. All programs now start to speak colorectal metastasis in cholangiocarcinoma, transplant in cholangiocarcinoma, colorectal metastasis. So what is the obstacles here to transplant this cholangiocarcinoma?
Until now, we didn't.
What is the obstacle in Egypt is what chemotherapy is preoperative.
Chemotherapy for cholangiocarcinoma is not effective. Secondly, patient with jaundice, cholangiocarcinoma, you know that we have a cadaveric program to try to get living donor take months. So the patient will be. Second, most of cases associated with lymph node positive. So if you missed one and the patient received immunotherapy after after transplant, the recurrence is very high. But we didn't proceed to transplant in cholangiocarcinoma up till now. Okay. Thank you very much.
Thank you. Now, Dr. Atif Abdul Ghani. Dr. Atif. Dr. Atif Abdul Ghani will talk about the management of giant liver
Mr. Chairman, dear colleague, the scientific committee Thanks a lot for this invitation that I will talk a little bit about the giant liver hemangioma. It's basically, and literally speaking, the giant liver hemangioma is a rare benign tumor. And as a matter of fact, this is the most frequent benign tumor in the liver. But basically, the giant liver hemangioma is uncommon because usually we saw these patients during accidentally, I mean the smaller type or the smaller hemangioma during the other laparoscopic or even open procedures. But the giant hemangioma that we are going to talk is uncommon. The hemangioma, as I mentioned, is the giant hemangioma. Actually, the lot of literature, they have a debate. Some literature said this is more than 5 centimeter or more than 10 centimeter. The case that I'm going to present today is actually involving most of the right lobe. Of course, the involvement on the the pathology actually is ectasia, and the exact etiology is not fully determined yet. Some literature are basically they attributed to congenital issue. And most of the hemangioma are asymptomatic. Usually the symptoms comes from the compression of the surrounding structures. And usually the main presenting symptoms is unrelenting abdominal pain, together with sometimes nausea and vomiting. Usually in the left lobe or left side. The complication, of course, the most important is Kaspach-Merit syndrome, which is basically a rare known complication of giant hemangioma. Diagnosis, imaging, basically the ultrasonography will diagnose and contrast enhanced CT, and characteristically with the late peripheral filling is seen after contrast administration because the blood circulation within the tumor vessel is low. The treatment strategies, basically somebody say we will be non-surgical management and surgical resection or enucleation. The non-surgical management, of course, in asymptomatic cases, or we patient with minimal symptoms, just follow up. The surgical management, patient was presenting with severe symptoms, as I mentioned, with unrelenting abdominal pain or the occurrence of complications. Enucleation, usually in certain and limited cases, you can enucleate the F12 capsulated and you can enucleate it. Otherwise, it will be very difficult. The other surgical procedures is basically the formal anatomic, or even sometimes you do the non-anatomic liver resection. Enucleation, the advantage is fit, actually with fewer complications compared with formal liver resection and reduced loss of functional hepatic parenchyma, as we know. The other interventional procedures are the two steps. Treatment with the transarterial embolization. Our case that we are going to present was not actually fit, or I mean eligible for, or a candidate for transarterial embolization. And then you can resect. After the transarterial embolization, of course, the size will be reduced and then you can resect this. I have a case, basically female patient, 55 years old, presenting with unrelenting abdominal pain in the right upper quadrant, and the laboratory work and workup was normal except for the HCV positive. She has hepatitis C positive, and ultrasound and of the abdomen showed a giant liver hemangioma, contrast CT as well, as you can see here, most occupying the whole of the right loop. Again, of course, bad quality of the CT, but you can see it clearly. And I have a video, small video if you don't mind. ممكن نعرض فيديو يا دكتور أبو هاب ولا؟ Can see the hemangioma on exploration, reaching segment 8, segment 7, and of course, segment 5. The decision was to do a formal right lobectomy with the extrahepatic control, the right hepatic artery, the portal vein. This is a vessel loop on the right hepatic artery with the gallbladder and cystic duct, the common bile duct. We always resect, they divide the right hepatic duct, the last step. This is the inferior vena cava with this vessel loop on the right hepatic vein, and then, of course, utilizing the equipments like the stapler and the energy sealing devices help a lot. With the lever retractor, of course, if you have this, you're going to have a very minimal blood loss, and you would save a lot of time. And unfortunately enough, this patient, we did that right lobectomy without blood transfusion. You can see the specimen occupying segment 8 and segment 7. Of course, this is the front, back. Giant hemangioma. Patient did very well post-operatively. You can see here after we resect the cava, skeletonized totally with the stable line on the right hepatic vein. And this is a cut surface of the segment 4, or the residual part of the segment 4, I would say. And then the patient did very well and discharged on the 10th post-operative day with very minimal bile leak. Of course, stayed for about 1 week or 8 days, and then we took out the drain and did fine. Of course, the benign lesion, usually the patients, as usual, they did very well. Thank you so much. I do appreciate your attention.
Thank you, Dr. Ar. Any questions?
No questions.
Thank you, Professor Dr. Atif, for this very nice illustrative case presentation and the problematic challenge. And any question from? Yes.
Thank you, my friend. In this case, if you did selective Bringle, right portal and the artery, and go through between the hemangioma and the normal liver, you have a capsule. If you go through the plane, the cleavage, you will remove the hemangioma. You can find small veins, you can clip it and preserve.
But you can see, Dr. Abab, it was not very well capsulated. You can see it was spreading all over several segments.
Thank you.
You're welcome. More questions?
Any other question? Thank you.
Cesar? طبعا
حضرتك في الحاله دي عملت فوليمتري قبلها وامبلايزيشن؟
ما انا قلت لحضرتك لا، احنا عملنا ام دي تي الحقيقه، وعرضناها على حد ايميننت برضو من عين شمس عشان ما تزعلش، وقال لي لا مش هينفع معاها خالص الامبلايزيشن.
لا مش قصدي امبلايزيشن هي اولا موضوع الامبلايزيشن الارتري انا مش شايف له اي فاليو خالص. تو ماي اكسبيرينس عمري ما شفت حد عمل امبلايزيشن وجاب نتيجه. انا بتكلم على بورتال فين امبلايزيشن تكبر ليفت لوب لانك تعمل فورمال رايت.
لا ما عملش امبلايزيشن، لا ما عملش امبلايزيشن الحقيقه. احنا بروسيد لان الحاله كانت الحقيقه يونج ايج هيلثي نورمال ليفر، فكان الحقيقه يعني ايه ستيميوليتنج. وكمان انت ما بتشوفش الحالات دي كتير قوي. as a matter of fact we don't see this large hemangiomas in our practice unless بقى الدكتور فتحي بيعملها كل يوم. this is another story بقى. صح؟
لا انا قصدي بس عشان تو بي سيف يعني للناس الباقيه كلها كمسج ان لازم قبل ما يبروسيد للرايت هيباتكتومي فوليمتري الليفت لوب. لقيت الفوليوم كويس اوكي.
لا هو كان الحقيقه في السي تي، ودكتور فتحي لو شفته وبقول لك نورمال ليفر كان سي ذا بيشنت. فاحنا يوجوالي في الامبلايزيشن بنعمله في التيومرز يعني في المالجننت تيومرز، انما في الهيمانجيوما وي دونت الحقيقه. مش عارف انت يو دو ات
اي ليفر ريسكشن ريجاردلس السبب بتاعه ايه. انا عندي ريزيدوال
لا في المالجننس الحقيقه انا اي دو ات سبيشالي عشان اعمل انهانسمنت للبريزيرفد بارت او البريزيرفد لوب عشان فانكشن ريزيدوال ليفر. انما اتفضل يا
دكتور عمرو.
اوكي
20% you can leave up to 20%.
In this case I did not do.
بس هو it is يعني احنا بنعتبره عندنا كرول ان احنا نعمل لو هنعمل اي حاجه رايت لوب او يعني فوكال ليجن رايت لوب لازم نعمل فوليومتري للليفت لوب.
This دكتور عاطف this is not lesion right loop, this is hemangioma and he removes the hemangioma not liver tissue. We never يعني very rarely do embolization for hemangioma, very rare. Yes, but the left lobe is normal liver. It's normal liver. It's not cirrhotic liver. It's normal liver, not GC, not cholangiocarcinoma. It's
so
different.
The main residual functional liver actually is the left lobe.
Yes.
Because the right lobe there is no functioning liver tissue because it's mostly occupied by the hemangioma. Would you agree? Maybe.
Thank you.
Thank you for this beneficial discussion, and thank you for Professor Dr. Atif. And now we introduce Professor Dr. Mamdouh Shirbini and the recent advances in the management of hepatocellular carcinoma.
Thank you for the organizing committee headed by Professor Abdul Wahab. Thank you for the panel and thank you for attendance. Recent advances in the management of hepatocellular carcinoma. The scientific content of this talk mostly delivered by the eminent speakers yesterday and this morning, so we'll try to summarize according to the short time of the talk. It is known that liver cancer remains a challenge of global health, being the fourth leading cause of cancer death worldwide. Hepatocellular carcinoma is the most common type of liver cancer. It's about 80%. Despite significant advances in therapeutics of HCC, it has high morbidity rates. HCC is the sixth common cancer leading cause of death worldwide, and in Egypt it is the first male cancer, and the second male cancer is urothelial carcinoma or carcinoma of the urinary bladder. As regards the etiology, it is well known that hepatitis C hepatitis B, although we are eradicated HCV completely, but still another risk factor is aflatoxin. And in a study done at NCI at the cancer biology department and the Mansoura microbiology department, it is proved that the concentration of aflatoxin in the serum of some patient up to 300 fold. As regard the diagnosis of HCC, still it is a radiological diagnosis, although it was a histological diagnosis in the past. Radiological diagnosis starting by ultrasound, triphasic CT, dynamic MRI, and PET CT has specific indications, especially for pre-transplant. As regard tumor marker, as you know, alpha-fetoprotein has high cutoff value in up to 20% of the cases only, and a study was done at NCI Cairo at the Cancer Biology Department and published at Journal of Cancer, revealed that for patient with patient hepatocellular carcinoma with normal alpha-fetoprotein, up to 60% of this patient has high cutoff value of alpha-L-fucosidase, which is of diagnostic value. And as regard histopathology, for the time being, still the diagnosis of hepatocellular carcinoma based on radiological diagnosis, which is a consensus. So why we can treat cancer or specific tissue, although we are in the era of molecular diagnosis, molecular targeted therapy, so we are in need for specific markers and biological prognostic markers, which is lacking in hepatocellular carcinoma. For the time being, we are depending on clinical staging, marker study, and radiology. So still we are in need for biological prognostic factors depending on serum markers, tissue markers, which I suggest even could be done for non-operative or non-operable patient. And in a study done at NCI Cairo, at that time, this study at the year 1995, about 40 cases of hepatocellular carcinoma. At that time, biopsy was done by me. I was one of the team. And it was found that there is a positive correlation between the grading of the tumor and the level of alpha-fetoprotein, and the grading of the tumor and porta hepatis lymph node metastasis, and the grading of the tumor and the level of alpha-fetoprotein. So, at that time, it was found that for high grade, you may have bulky disease with portal lymph node metastasis with high level of tumor marker. As regard immunology, still we are in need for a studying of the tumor microenvironment of hepatocellular carcinoma, which is different than other types of cancers, because we are in the era of immunotherapy and immune targeted therapy, and we should study tumor infiltrating lymphocyte, dendritic cells, and PD1 or programmed this1, PDL1 programmed this ligand 1 for triggering this by immunotherapy. Immune checkpoint inhibitors blocking programmed this ligand 1 or programmed cell this 1 have transformed the treatment landscape for HCC, especially for non-resectable HCC. Several systemic options have been approved for first-line therapy, Atezo and Biva, which is the famous protocol. Atezo and Biva atezo is a monoclonal antibody against PD1, PDL1, and Beva or bevacizumab, which is anti-vascular endothelial growth factor against vascular endothelial growth factor. And Durva, Trimo, sorafenib, and lenvatinib. Also, immune checkpoint inhibitors could be combined with sorafenib or soranib, which is a tyrosine kinase inhibitor. So we are in the era of single agent for non-resectable versus combined and ongoing trial for combination treatment. In conditions, several second-line agents such as regorafenib, which is also a tyrosine kinase inhibitor, for patient not responding or failure to sorafenib or Nexavar. Many ongoing trials are investigating a novel strategic involving tyrosine kinase inhibitor in combination with immune checkpoint inhibitors like pembrolizumab and Nexavar or sorafenib. Local regional treatment in combination with immune checkpoint inhibitor and neoadjuvant therapy potentiate the effect of immunotherapy because local treatment, either resection, radiofrequency ablation, even TACE, potentiate T lymphocyte and increase or modulate the efficacy of immunotherapy. Most patients with HCC have underlying cirrhosis, and as mentioned in this morning by Professor Abdul Wahab, up to 80% of our patients with HCC on top of liver cirrhosis, which significantly impact their health performance studies and ability to tolerate surgical and local regional and systemic treatment. As a result, treatment of hepatocellular carcinoma in Egypt should be individualized. Currently, there is a widespread global consensus among clinicians to base treatment of HCC on the tumor according to tumor staging, which is the non-Barcelona. I mean, for early stage disease 0 to A, for local treatment, B for TACE or for a local regional treatment, and C it should be individualized for treatment, systemic treatment or not. Prognosis of patient with HCC correlate well with their Barcelona staging. Yes, median survival ranges from greater than 10 years in patient who receive liver transplant plus local therapy for early stage to more than 6 years for patient who undergo resection only. Approximately up to 30 months for patient with intermediate stage HCC, and approximately 19 months in patient with advanced stage with compensated liver function, a child above A cirrhosis. These outcomes are significantly improved in the era of immunotherapy by adding immunotherapy either for adjuvant or neoadjuvant. Systemic therapies. In treatment naive patient with unresectable HCC, again, you can start by single or combination. Single, which is sorafenib, and again, this drug prolongs survival by few months only, and as mentioned, it is used without any marker study, without any prognostic factors. And after failure of sorafenib, lenvatinib has been shown to be non-inferior. Both atezo and beva, the combined protocol again, has a better survival. This is the development of systemic chemotherapy, systemic therapy for hepatocellular carcinoma started by sorafenib at the age 2007, and then regorafenib, which is also tyrosine kinase, at the age of 2017, and lenvatinib, which is a monoclonal antibody, and pembrolizumab, which is Keytruda, at the age of 2018, and again cabazitatinib and ramucirib at the year of 2019, and the well-known protocol again atezolizumab at the year 2020, and by the year 2022 durvalumab. Currently approved tyrosine kinase inhibitors and anti-angiogenic agent for treatment of HCC. It is a well-known trial, which is a SHARP trial. Again, tyrosine kinase inhibitor and bevacizumab or Avastin, which has a specific precautions, because Avastin or bevacizumab, which is an antiogenic agent, should not be used for patient with possibility of risk varices. So upper GIT endoscopy should be done with ligation or manipulation of risk varices, and should not be used for patient with peptic ulcer and for patient with immunological disorder. Ramucirumab, a monoclonal antibody which target vascular endothelial growth factor also receptor 2, was studied in a placebo-controlled randomized trial in patients with Barcelona stage B or C HCC who had shown a progression on sorafenib. Currently approved checkpoint inhibitors in the treatment of HCC, again beva, atezo, and for treatment of patient with hepatocellular carcinoma in Egypt, it should be, yes, it should be individualized. Combination approach. The promising activity for combination, not for single agent, especially for immunotherapy. And immunotherapy could be used either single or combination, and there is ongoing trial for using immunotherapy post-operative, and also possibility of uses as maintenance therapy. The most recent analysis show a median overall survival about 20 months in patients who received atezo and beva. Ongoing evaluation of combination. Okay. Management of hepatocellular carcinoma in a special population, especially for patient non-resectable, single versus combination, and patient with recurrent hepatocellular carcinoma after transplantation. Most of these studies is not a randomized trial, and in a study of 7 patients with recurrent HCC after transplantation, for this 7 patients, after using of monoclonal of immunotherapy, one patient has complete remission, 2 patients has stopped treatment, and 3 patients has rejection. So this is an individual issue and still ongoing. Conclusion. The treatment landscape for advanced HCC has transformed over the last decade. Immune checkpoint inhibitors are now the backbone of most treatment strategies in clinical practice. Combination is more beneficial than single agent, which is still ongoing trials. The incorporation of systemic therapy in the management of early stage and intermediate stage HCC and further advances is effective combination for advanced HCC. So for combination more than single. Thank you. Please for question and comment.
Thank you, Dr. Mamlouh. We are short of time. معلش ما فيش بقى questions.
Yes.
We'll go up to the stage. حضرتك عايز تسأل؟
Yes.
شكرا دكتور ممدوح باشا. You are my friend.
Yes.
First of all, you mentioned that from 40 patients with HC, you have find lymph node metastasis.
Not all.
يعني 1, 2, 3, 4, 5.
About for it for in the majority of patient with grade 1, grade 2 and grade 3.
Never grading in HCC. I'm more like HC.
For histopathology, I mean histopathology.
Yes.
At that time, histopathology was
Yes,
mandatory.
you have lymph nodes.
Yes.
In our experience, we have 400 cases for transplanted, and pre-transplant investigated by CT, MR, and PET scan. We didn't find any case with lymph node or lymph node 2 because the drainage of the lymphatic pathway of the liver not go down, go up, as you mentioned.
Okay.
No para-aortic or celiac or mesenteric or vertebral.
Okay.
Yes, this first comment. Yes. Second comment. هترد عليهم بقى.
أرد دلوقتي؟
لا كلهم.
طيب.
Second comment, as we know all of us here, HCC developed in 95% of cirrhosis, and 95% of HCC on top of cirrhosis. Only 5% normal level. يعني you have
Yes.
tumor and cirrhosis.
Yes.
If it is resectable, على الرغم من انه resectable, life is bad short. If you do transplant, برضه it is short. I think it is better now to leave the patient with his immunity to die in peace after 1, 2, 3, 4, because you have growing of pre-malignant. In England years ago, they reported that sarfunab not for HCC and prohibited there.
For RCC, yes.
For HCC. But why? قال لك ده for renal tumor, and they studied patient with or without sarfunab, the life span فرقت 1 month with complication.
Yes.
Do you believe that?
Yes. As regards the first yes.
I want to ask you, for 40 patients, you do this study. How many patients that tumor disappeared completely?
For you are my professor, and I know that porta-hepatis lymph node. Yes, I'll answer. Could occur even for cirrhotic patient without HCC. Yes. Yes, I know. And in the 40% of 40 patient, about 30 patient with porta-hepatis lymph node, which is not malignant completely. It is a minority only. Yes, I know it is a minority only, and diagnosed yes by CT. Yes.
Second.
تاني لو كان. Yes, as regard, I am not going to promote for sarafin. I am only illustrating the literature, and for the time being, we did not use this drug because it is it is beneficial only for 2.5 months, which does not worsen the complications and the financial cost. I'm not prescribing this drug.
So it is ethical to have a patient with tumor 3 centimeter with 2 months under chemotherapy or immunotherapy.
No.
Now we should
Upfront surgery, for upfront surgery.
I didn't mean surgery. يعني تدي العيان تيومر 3 سم او 4 سم سيروتيك ليفر تمشيه مانسز على كيموثيرابي او اميونوثيرابي.
No. No. For upfront surgery يا بيه.
اوكي ثانك يو.
Thank you.
معلش هو ده مشكله كبيره وعايزه ساعات وساعات علشان نوقف الابيوز.
Thank you very much. And we are late more than 1 hour. And we have to introduce Professor Dr. Ibrahim Abdul Qadir, staging system for hepatocellular carcinoma. If there is an ideal one. Please, if we can stick to time. Professor Abdul Qadir. Professor Abdul Qadir. We hope to stick to time.
ماشي انا اخر واحد ده عشان جت عليا يعني. بسم الله الرحمن الرحيم. Mr. Chairman and my colleague, first I would like to thank Dr. Professor Abdul Wahab for this elegant meeting. Our talk about completing the topic of HCC. This article was 100 years ago in 1929, almost 100 years ago, states that the primary carcinoma of the liver is little practical importance. It's very rare, but nowadays recently discovered as but rapidly involving everything. The most common, 6 most common cancer in the world. Second leading cause of death from cancer after lung cancer, leading cause of death in cirrhotic patient. HCC mortality increasing in Egypt. This is statistical by National Cancer Institute, about 6,000 to 7,000 deaths annually due to HCC. All we know that the hepatitis C has risk factor for HCC. We know all this multi-step or cascade phenomena, normal liver, hepatitis C or B, or NASH, liver cirrhosis, dysplastic nodule, and HCC. Also, HCC is a bad prognosis among the whole cancer of the body. So staging of HCC to dictate therapeutic options. Staging system for cancer are guides for prognosis, making therapeutic decision. Staging essential to comparing group in therapeutic trial between studies. Good staging system should be simple, easy to use, reproductive, provide relevant information on the natural history, permit categorization patient for treatment. All this can do with all cancer of the body except HCC. It's a many factor. You have look for liver, hepatic synthetic function, tumor characteristic, and the overall health. In the liver, you should be categorized or evaluated by, or assisted by child classification, tumor TNM classification like other tumors, and patient performance status of the patient. Very many staging for HCC. Most popular use it BCLC is hepatic function by child classification, performance stage of patient, and size of the tumor, number, portal vein, thrombosis. So stage 0 and stage A, consider is it small tumor less than 2 centimeter, no portal hypertension, normal bilirubin. Stage B is multinodular child A or LB. Stage C is vascular invasion or extrahepatic spread, child A or B. Stage D is any tumor performance status may be bad, shall see. We have also 5 category of our performance status of patient. Most of our patient for surgical fit go through this A and B, performance status 0. And all patient with stage D BCLC goes through stage 3 and 4. So BCLC's classification is linked to humor with treatment strategy, dividing HC in 5 stages according to the prognostic variable. Allocate suitable therapy according to stage. So, very early stage is a curable therapy. Intermediate stage maybe test is potential palliative therapy, and terminal is symptomatic treatment. Early stage HC is after surgical or liver transplant, 9% 5-year survival. Stage C, 5-year survival up to 70% after surgical treatment, whether resection or liver transplant or local ablation. Stage C also, C is with sorafenib, median survival is decreasing to up to 25%. Stage D is in the stage liver disease, and which is C, so just symptomatic treatment. So, if you look at this staging system, you categorize the patient to early and late only, and intermediate just palliative treatment. TACE is not a definite treatment, like this one. So our problem of surgery, we have early HC, early stage and stage 1, you can do resection, liver transplant, or any type of ablation. And terminal stage is symptomatic treatment. We have problem with this stage, intermediate stage. Because the statistical from National Liver Institute over 7 years in the HSC clinic, we can see here the options is collectively here. Option of treatment for 7 years is 9,000 patients, most of them categorized as intermediate stage. So more than 6,000. So 70% of patients of HC by BCLC is not treated. It's just palliative therapy. So this heterogeneity of the intermediate stage of HC and the heterogeneity of the patient with intermediate stage BCLC, hepatic carcinoma, proposal for sub-classification to facilitate treatment decision. So we can do. So you are satisfied by this BCLC? No. Because it's too conservative. Just treat 0 and no, stage 0 and 1 only. And we are a surgeon, consider that the role of liver transplant should be extended. The role of curative resection should be extended to involve more patients, not recommending BCLC, like multifocal within one lobe, lobar or bilobar, HC with limited vascular invasion. Large HC, what's about large HC? And also should be radio frequency or microwave should be extended from 3 centimeter to 5 centimeter. So, like this case, resection with this patient with multi-focal lesion but confined to one lobe, so you can resect it. And resection for unilocular multifocal HC is comparable with solitary nodule. Also, we can use many modalities for patients with HC, combined resection and ablation for bilobar multifocal HC. So if you have right lobe and caudate mass, so you can resect right lobe and ablate the caudate lobe in the same session in OR. So combined treatment versus resection alone is no hospital mortality in both group and comparable in both group. Also, if you have a large HCC with macrovascular invasion, you have this patient occupying right lobe or right lobe, and here right portal vein invasion. HCC is a hemotumor. HCC is never or very rarely metastatic outside the liver. HCC like the liver. It's like a liver. HCC spread inside the liver. So the mode of spread of liver HCC, first the liver, second liver, third in the liver, 4 in the liver, 5 extrahepatic, maybe to the lung, bone, adrenal. So we can resect this patient with HCC with macrovascular invasion. We can see here the tumor and this thrombus. HCC thrombus never invade the portal vein, invaginate. Invaginate the portal vein, not invade. Tumor invade microvascular and go through right or left portal vein, so you can remove this thumb. So it is invaginal. So you can resect this patient, and resection for HCC with macrovascular invasion is comparable without vascular invasion. So what about large HCC? Benefit of surgery. Prognosis result of after resection is very large, more than 10 centimeter for HCC. Although recurrence are common after resection of this tumor, overall survival was not significant difference between resection of small HCC or large HCC. Outcome for resection of giant HCC in the tertiary center, does the size matter? But sometimes in this patient we have a large tumor, but remnant liver is not enough. So you have to look for resection of volume, future liver remaining as a normal liver we can resect, and we leave down to 25%. In fatty liver or chemotherapy patient can 40%. In cirrhotic should not less than 50%. So options of giant HCC resection was enough future remnant liver, resection exophatic giant HCC, resection of giant HCC with the risk of major resection, like this one. This huge left lobe giant HCC is size missing في البيس. So we can resect this right lobe at good volume. So we can resect HCC with minor resection. Also this patient with left lobe, HCC taking whole left lobe, we can resect the left lobe and the remaining volume is good for this patient. Also, the patient with normal liver cirrhotic, only caudate lobe mass. You can remove the caudate lobe resection with remnant or good remnant liver remain. Exophatic giant HCC, like this patient, giant HCC, just huge HCC reaching down to the pelvis, just connected with the liver with pedicle. So MBCLC, don't touch this patient. Why? You can resect this patient. You can resect this giant HCC with minor resection. We have enough future liver. Come to right lobe with central giant HCC, and seems a left lobe is not enough, and this tumor taking whole right lobe. So if you're going to resect this, the patient can have a post-operative liver cell insufficiency. For need former right or extended right, if remaining left is not enough, cirrhotic, so need extra tissue of the liver left up to 50%. So we can do atrophy hypertrophy complex of the liver, volume shift. is a regulatory compensatory response to the liver injury that re-establish the whole liver volume constant. عرفنا الحاجات دي منين؟ من liver transplant، من lobotomy، من lobar portal vein thrombosis، lobular bile duct occlusion, related lobe atrophy and other lobe hypertrophy. So we can use it by induce atrophy of right lobe or consequently hypertrophy of the left lobe, maybe by intervention, close the right lobe, and so give chance for left lobe to be hypertrophied. This is a technique adopted by M.D. Anderson in first percutaneous portal vein embolization. Portal vein embolization before partial hepatectomy can be done surgical right portal vein ligation, or Albus associated liver partition, portal vein ligation for stage hepatectomy. So go back to the last patient. So after TACE and to do a volumetric study, we can do Albus here, and Albus should be this, divide the liver like a book. And after a week or 10 days, you go back and resect the right lobe, and volumetric study shows the left lobe is more hypertrophied, and the patient now is sufficient liver remaining. So, in conclusion, BSLC staging is too conservative, providing many patients for curative chance. Curative surgery as well as ablation can extend more and more to benefit patient for intermediate and advanced stage of HC. So, intermediate stage of HC should be subclassified to narrow the window of heterogeneity of the stage, and will offer more precise selection of the group patient who are often suitable for more aggressive therapy, which lead to better survival of our patient. Thank you very much.
Anybody to comment?
Thank you, Professor Ibrahim, for your excellent presentation. Please, it is a little bit practical question. After hepatectomy, either right or left, as you know from the biology of the tumor, hepatocellular carcinoma developed in a multi-stage of carcinogenesis. I mean, initiated cells, promoted or promotion, activation, progression, and frank malignant cells. So, as mentioned by Professor Abdul Wahab, not less than 80%, 90% of our patients with HCC on top of cirrhosis. So, after even formal hepatectomy, you may develop another new lesion. What about the incidence of this in your series, and you are dealing with it again local, or what about the problem? Thank you.
Okay, HCC, one of the most drawback of the HCC is a recurrence. وانا بفتكر كلمه بيلديج من فرنسا، لكن الليفر سكشن دي ما بيوضش وشك، ما بيوصلكش، ما بتعمل ريفر سكشن. ريكرنس بيحصل ريكرنس، but you can deal with it. You can go another session or do resection of this recurrence, or can you have many modality like local ablation, radio frequency, or microwave, or azonol. There is many modality to dealing with recurrence after HCC.
شكرا بروفيسور دكتور ابراهيم، شكرا. Then we came to Peter and Hussam Suleiman and with the symposium.
see it already? Okay, my name is Peter Bernhardt. I'm from Bremen in Germany, working for Mavis Medical Solutions, and I'm honored to be here. You do not see the presentation? So we have to do the presentation first. So this is a 20 minutes talk, and I will start with an introduction of how our software can help with liver transplantation and the planning of complicated liver surgeries. And will take about 10 minutes. After that, Professor Suleiman will do some case studies, and after that, we can take questions. Yeah? And I'm still not seeing the presentation right now.
Camera. سسرع. Camera.
Oh, now we see it. Okay, good. It was the cable over here. Fixed it. Okay. I'm going to talk about the Mavis Liver Suite and Mavis Distant Services. Liver diseases, cirrhosis, liver cancer, and metastasis in the liver can cause liver surgery. And the oncologic liver resection is the creative gold standard here. And in liver transplantation, in a special field is the living donor liver transplantation that we focus on in our software. There are there are challenges that we try to solve and help you surgeons with. You have a very complex 3D anatomy with the vessel system spread over the liver segments, and also on top of that you have a high diversity of patient individual anatomy. And if you do surgery and you still need to ensure the sufficient liver function in the patient and in the donor. This is what you commonly get, contrast-enhanced CT images. And at Mavis in Germany, so we have a very well-established service. Since more than 20 years, we are working on cases, liver cases. You can upload your CT images and MRI images to our server. And what is new, we are now offering this service through BIFA Health in Egypt exclusively as well. So we get the multi-phase CT and an MRI image for the visualization of the bioducts and combine this to a very nice model of the liver. On top of that, we can give resection proposals, standard scenarios for LDLT, and also for tumor resections. And with that, you always get the volume information. You get the segmentation, the volumes of the segments, and the volume. And you can already see here in this example that the remnant volume is only 34% of the liver, but it is still sufficient to proceed with the procedure here. Then the results go back to the hospitals all over the world or in Egypt. And the results are published, or you get this as 3D HTML files that you can use upfront your surgery or even in the operating room. On top of that, we support living donor liver transplantations, liver resections, but also visualization of the pancreas, kit for kidney transplantation, renal tumor is also possible. This is the summary. The service is a professional service for image segmentation and 3D visualization. So the work is done by a specialized quality-controlled team in Germany or in Egypt by BIFA Health. Now, what is new? The software that we developed over the 20 years, all our experience went into a software that is now CE marked and FDA marked already, and it is called the Mavis Liver Suite. And the Mavis Liver Suite can be installed in your hospital transplant center so that you can work on your own cases. You can plan the grafts in LDLTs or plan oncologic liver resections, visualize veins and arteries from the CT and the bile ducts on base of the MRI images. And AI helps you to do the segmentation of the liver and gives the volumetry and also of the vessel system here. The liver is segmented automatically, also portal vein, hepatic veins, hepatic arteries, and bile ducts. With that, after the segmentation of the vascular system, the vascular territories are automatically calculated, and you get the 9 liver segments or the 8 liver segments with the volume in milliliter and relative to the total liver. Again, like with the service, now you do that in-house. You have your own CT images that you get from radiology. You have the MRI image and combine them to a very nice model here. You can also define and compare surgery scenarios, the absolute and relative volume of remnant and graft, the graft to recipient weight ratio, which is an important factor. The graft to standard liver volume ratio is also that you get in a nice presentation here. You can export and share the results. You can review them in an application that we call the Mavis Suite Liver Viewer. You can also use the HTML files that you can review everywhere if you have a browser. You can do an DICOM export to PACS, and you can also export STL and OBJ objects for 3D printing and use in virtual reality glasses. Another point or an argument for choosing this solution is that you can use and combine with the service. Let's say you have a shortage of staff, or you have a very complicated case where you need consulting on. You can, in addition, use the service and get the consultant from our expert here. Thank you so much. And now we go to the second part where we see some case studies. Thank you.
بسم الله الرحمن الرحيم. السلام عليكم جميعا. Okay. مش في دي. Yeah, it's an honor for me to present the recent experience. It's a good news to have Mavis here in Egypt during the last 2 months, and we are cooperating with them to assess and develop this great experience in Egypt. We have this is a good news. I will present here another 2 good news. We have performed with them 14 cases assessment. 2 cases were done for a laparoscopic donation. The first 2 purely laparoscopic living donor transplantation in Egypt, and also central resections and major resections, and with the usage of the software in recipient assessment and cases with portal hypertension. The first laparoscopic donor was done 2 months ago in Dar el-Fayed Hospital. She's a mother donating to our child with 7.5 kilograms, biliary atresia post-Kasai operation. This is what we get, usually we get. This is done by one of the best centers. It was done in Mansoura, one of the best centers in Egypt, I think, this one. We can get most of the knowledge through the multi-detector CT conventional images that we have, and also we can have it in a form of reconstruction, but the defect that we have all separate. You know, the arteriography and venography is separate, the MRCB is separate, the volumetry is separate. We don't have a model incorporating all these three together. And this is the advantage of the MEVIS model. The model, we have a very simple output in an HTML file. We can navigate and browse this output through a mobile, laptop, or any digital media with extensive assessment for the donor or for the recipient or whatever the case we can use. In this case, there are two hepatic arteries for a left lateral, and also the details of the experience. The most important is the incorporation in a 3D way of all the structures together, including the biliary reconstruction. But we need standardized scans for having the best outcome. On this particular donor, there were the cutting line. There were two specific veins that were clearly explained or clearly demonstrated by the analysis through the cutting line. And during the cutting line, it was quite simple because we know in advance what we will meet, where we will meet, and we plan what we will do with these structures. This is the first vein. It was a portal branch, a significant portal branch to segment 4. And also, this is a left lateral donor, so there was a significant hepatic vein crossing the cutting line, was also controlled. And through the CD through the 3D model, we know that the location of the planned cutting line exactly for the bile duct, and this is a cutting of the bile duct with a branch. This branch was clearly demonstrated in the model, so we ligated and cut. Now this is the graft harvesting the accessory hepatic artery, or the small artery originating from the celiac, from the common hepatic artery. And the left gastric artery dissected through its origin. The portal vein is cut, and then the hepatic vein with a stapler. We used this in another donor for an adult patient with a left loop, and planning to do for every donors. Planned for laparoscopic. The second case is a female patient, 54 years old. She had no medical history, negative virology. However, she had history of oral contraceptive pills and presented with progressive pain and anemia, and had a huge mass by ultrasound confirmed by CT and MRI. This is a CT scans. There is a big central mass occupying most of segment 4, segment 8, and segment 5. Yeah, mainly in 4A and 8. And this is the reconstructions, biliary and vascular reconstructions. With a MEVIS model, we can have this model. You can navigate, you can see it from all the views. At the same time, you have the relations to all the structures: hepatic vein, portal, arterial, and biliary. At the same time, what is the assessment gives you is gives you tumor margins or relations to the tumor, and also the suggested resection lines. Here we will zoom for this, the biliary relations. You can see it in advance. You can plan for using the software and relation, and it's almost what is actually have seen in OR. These are the photos, the central resection, the portal pedicle of the posterior sector, the IVC, right hepatic vein, and middle hepatic vein. and the resected specimen. And this is the cutting line of the video is a little bit rotated, I think so. But and in all of these cases, we also apply the Globran, which is another product for hemostasis of this big or huge cutting surface. It's very beneficial for hemostasis and also for biliary, for the biliary leak. It has a documented effect on the biliary leak. It's better to use it with the applicator. This is the open applicator. What about portal hypertension? This patient specifically was discussed in a meeting. She presented with neonatal portal vein thrombosis. We are arguing about the proper decision for this patient and whether to do a shunt or so. But with the extensive analysis, you can have the proper decision now. You will have, she's having a recanalized left gastric vein, and she's having another shunt. And actually, she doesn't need to do further shunting or further surgery because the bleeding is self-controlled now. With the MEVIS now, we are developing some kind of a standard assessment in recipient with complex vascular problems like portal vein thrombosis, and also with those who in pediatric transplantation, especially for the assessment of the shunts and to avoid portal steal and vascular complication in the pediatrics. The model allows us to see extensively all the shunts and their location, and we are developing with them to have a standard with the incorporation of the pancreas, incorporation of the spleen and left kidney to have a definite location of the shunt and to have extensive plans for the surgery. This is another case of a recipient. It's the same. The relations, we have here two left gastric vein, inferior mesenteric vein, long inferior mesenteric vein. Avoidance of ligation of these veins, significant veins, usually leads to some kind of portal steal and portal vein thrombosis. So far, we used the MEVIS analysis in 14 cases. 2 donors were done laparoscopic, and 2 donors were planned for open donation. 2 pediatric recipients and 2 central hepatectomy, and 1 patient with portal vein thrombosis and portal hypertension. For the Globran, we have a comparative study now going on in our National Liver Institute to compare the cirrhotic resections, effect on cirrhotic resections, and also the effects on biliary leak post-donation and post-resection. Thank you, and we are waiting for any questions.
Thank you for keeping the time. And now, any question for Professor Peter or Professor Hussam? Thank you. Thank you. For the next session, Professor Dr. Jamal Musa, Dr. Khalid Al-Fiqi, Dr. Mohsen Salim, Dr. يحيى زكريا, Dr. أيمن صالح. اتفضلوا على المنصة.
مساء الخير على حضراتكم. It's a session about pancreatic surgery. We are in short of time because the sessions ran very slowly in the past sessions. So I'm asking all the speakers to stick to the time because many of our fellows and friends here are traveling after finishing this session. We'll start with Dr. Peter. No. دكتور عبد الهادي من الأردن. أهلا بك دكتور عبد الهادي وصاحب المكان. He will speak about glucogonoma up to date in the management.
بسم الله الرحمن الرحيم. السلام عليكم مرة ثانية في هذا اليوم اللطيف الجميل. Mr. Chairman, dear colleagues, I will be short. What's glucogonoma? I think because there are many students here and residents, so we have to change from the morning session. Very rare tumor of islet cell tumor. 120 cases reported until October 2003. Why? Because this is my first case in 2003. Originate from alpha 2 cells of the pancreas, exclusively localized in the pancreas and in about 70% in the tail. Leads to an excess of hormone called glucagon in the blood. So average tumor size is 3.6, metastasized to the liver and distant organs. What is the disease? No particular race specifications. Male and female are equal, although greater incidence are reported, unfortunately, in females. Average age is around 55 years, between 19 and 40. Again, very rare. Only about 2,700 cases of neuroendocrine tumor in the United States until January 2023. Glucogonoma with islet cell neoplasm accounting only 1.3 of the pancreatic cancer. This is the skin lesion to the different parts of the body when there is this part of the syndrome caused by the glucogonoma when it's active. What are the causes is unknown, but family history of the syndrome called multiple endocrine neoplasia type 1, which is a tumor syndrome, is a risk factor for glucogonoma. What are the signs and symptoms? There are many. Diarrhea, excessive thirst, urination excessive, increased appetite, inflamed mouth and tongue, night urination, and there's a 6D. What there's D? Decline of the weight means weight loss, dermatitis, necrotic erythema, migratory, depression, deep vein thrombosis, and diarrhea. How we diagnose? Localizing studies are ultrasound, CT, primary pancreatic tumor with metastatic disease, arteriography, prominent tumor blush, hepatic metastasis, and maybe transhepatic venous sampling. What are the complications? The cancer can spread to the liver. High blood sugar levels can cause metabolic problems, tissue damage, and high rate of thromboembolic complications and pulmonary embolism. What is the treatment? Surgery, reversal of clinical and laboratory abnormalities. Non-surgical, unfortunately, but reduce the bulk of the tumor, and many drugs can be used like these drugs. Surgery to remove the tumor usually doesn't respond to the chemotherapy of the tumor. Currently, there are no drugs used to treat glucogonoma as a radical treatment, but you can provide supplemental protein supply in order to furnish amino acids is useful. Administration of fatty acids and minerals is also useful. What about survival and prognosis? Approximately in 75 to 80% of the tumor starts in malignant form. And in 50% of these 80%, these cases metastasize already exist at the time of diagnosis. As we said, if it is concerned to the pancreas, if it is contained to the pancreas without metastasis, the person has approximately a 5-year survival rate of 85%. Some patients live over 20 years without therapy or surgical excision if benign. In malignant cases, surgical cure in 10%, and in 50% of patients, survival rate more than 5 years. Plasma glucagon, excellent marker for a tumor recurrence and follow-up. I will present a case. Rushdie, 50 years old, in 2003 came to the clinic. He is diabetic 10 years or 11 years before that. On complaining of uncontrolled blood pressure, easy fatigability, weight loss for at least last 6 months, ultrasound, huge homogeneous mass in the head of the pancreas, not in the tail, and with central necrosis and calcification. The patient transferred to surgical ward, and our ward examination shows muscle wasting, vital signs unremarkable, abdomen no tender, fullness in the epigastrum, oral cavity is free, no skin rash, contrary to expectation. This is the patient, look, cachectic, 2003. Investigation, normal, apart from SGPT or GOT elevated, and HB 12 gram deciliter. This is his CT scan. You look here, this is the mass, and this is the calcification. Huge mass at the area of the head of the pancreas, very huge mass. Okay, surgery done, and pancreatidectomy was done. As you see here, the duodenum, this is here the mass open, and here this is the stomach pylorus, here the specimen. The pathology, encapsulated mass inside the pancreas. Remember, we said this confined to the pancreas, consisting of cells that form solidness as well as ribbons, phytons, gyriform pattern with focal amyloid-like material. Lymph nodes are reactive hyperplasia, stomach, duodenum, adjacent pancreas not invaded. The diagnosis, islet cell tumor. It is confined to the pancreas. Actually, when I do pancreatic jejunectomy, I am always use transjejunal drainage of the pancreatic duct and stent outside to control the fistula and to prevent fistula formation and for radiological study. What happened in the 12-day post-op? Upon removal of the abdominal drain, the patient developed massive internal bleeding. Immediate laparotomy, we found there is a mesentery, blood vessel for the mesentery stopped, and the bleeding at the time. Whole body scan showed solitary bone lesion, as this you look here, at the 12 rib, but not attributable to malignant metastasis. They said maybe old trauma because the patient is still alive. High scan showed that good uptake and drainage to the biliary, to the jejunum. I didn't follow the patient up by myself. He lost 3 months ago, it means 20 years later of his operation. I received a call from a hospital in Jordan called Abdel Hadi Hospital. My name is Abdel Hadi, but there's a private hospital for one doctor, by his name is Abdel Hadi. The patient came with obstructive jaundice to the hospital, his biliary tree, MRCP, there's stone obstructing the anastomosis. He came to Al-Bashir Hospital where I used to work, but I retired. He asked about me, they said to him he is retired. He thought that this hospital, Abdel Hadi, is my hospital. So he went to the hospital and he called me from there that I have a problem, I want you to treat me. I saw him in the outpatient clinic and I take a picture with him 20 years later of his operation, and I sent him to my colleague in the governmental hospital and removed the stone from his obstructed anastomosis. I want to say hyperglycemia, anemia, and muscle wasting may be the only presenting feature of glucogonoma. Not always there is a skin rash. Thank you very much.
We will postpone the discussion till the end of the session.
I say 5 minutes.
Okay.
I see. Okay. Thank you.
Thank you, Professor Abdel Hadi, for this nice presentation. And the next speaker, Professor Amr Mustafa. speak about classification of complications post-pancreatic duodenectomy according to modified Cleveland Dendo score. اتفضل يا دكتور عمرو.
بسم الله الرحمن الرحيم. طبعا بشكر استاذنا الدكتور محمد ابو وهاب على المؤتمر القيم واللي بيسمح لنا كلنا ان احنا نقول our experience in our institutions. وبشكر برضو كل المنصة وكلهم اساتذتنا. النهارده هتكلم على classification of complication of post pancreatic duodenectomy according to modified Cleveland Dento score. Pancreatic duodenectomy is the treatment of choice for various benign or malignant tumor of the pancreatic head of the periambulary region. Pancreatic resection rank as one of the most complicated and technically challenging surgical procedure. As experience increased and advances in technical and perioperative care, dramatic decline in observed in both mortality and morbidity. Currently, high volume pancreatic surgical centers are consistently reporting mortality rate of less than 3% and morbidity rate still high 30 to 40%. With the progress in pancreatic duodenectomy, medical center face the problem of absence of definition and widely accepted ranking system to classify surgical complication, which has hampered proper interpretation of surgical outcome data. Dr. Pierre Allen Cleveland in 1940 modified the original classification by placing great reliance on the therapeutic procedure required to treat the complication to indicate the severity of the complication. In 2004, Dendo developed a new 5-scaled classification system with the aim of presenting an objective, simple, and reliable way of reporting negative event after surgery. سريعا الكليفيان سيستم الجريد 1 اللي هو any deviation from normal post operative course without need for pharmacological or surgical endoscopic or radiological intervention. Grade 2 requiring pharmacological treatment with drug other than allowed in grade 1. Grade 3 requiring surgical endoscopic or radiological intervention. Grade A with local anesthesia or with general anesthesia. Grade 4 life-threatening complication requiring ICU management, single organ dysfunction or multi-organ dysfunction. Grade 5 death of the patient. This is a retrospective study done in National Liver Institute for the past 10 years. All data was computerized. We have 404 patients were included in this study. Male about 60%, female about 40%. The age range from 20 to 82. The weight range from 49 to 112. The BMI was 21. Most of the comorbidity was the weight loss, second diabetes mellitus, hypertension, cardiovascular disease. Our diagnosed pancreatic head mass in about 78% of cases, distal CVD structure in 0.5% of cases, duodenal mass in 2% of cases, periambulary mass in 19% of patients. The pathology was adenocarcinoma for about 90% of cases, chronic pancreatitis in 4.6% of cases, cystoadenocarcinoma in 1.3% of cases, mucinous cystic neoplasm in 3 cases, neuroendocrine carcinoma in 3 cases, hemangioma in 1 case, GIST in 1 case, lymphoma in 1 case. Lymph node was positive in about 27% of 27 cases. 27 cases. Type of operation classical Webel in 88% of cases, pylorus preserving in 12% of cases. Pancreatic anastomosis was done duct mucosa about 80% of cases. Pancreatic osteotomy dunking 39 cases. Pancreatic gastrostomy duct mucosa 35 cases. Pancreatic gastrostomy dunking 2 cases. Vascular invasion can about in 24 cases. Vascular reconstruction occurred in 1 case. Texture of the pancreas soft in 158, firm in 246 cases. Pancreatic duct diameter less than or 3 millimeter in 165 cases, و more than 3 millimeter in 239 cases. Regarding the post-operative, the operative time range from 4.5 to 10 hours. The average 6 hours. The post-operative ICU stay range from 1 day to 30 days. The median 3 days. The hospital stay range from 7 days to 37 days. We have 162 cases had 1 or more complications, about 40% of the study. We have post-operative pancreatic fistula. Grade A is treated conservatively. Grade B, we need to insertion, have to pigtail insertion, stayed for about 2 weeks to 2 months. Grade C can 8 cases need re-exploration. Delayed gastric emptying grade A كان 28 patient ودول خدوا supportive care and delayed removal of NG tube. Grade B 11 cases, most of these cases need reinsertion of the NG tube with metoclopramide and sometimes erythromycin. Grade C كان 5 patient ودول كان associated برضو مع البنكاتيك فيستولا و improved after re-exploration و support مع التي بي ان. بالنسبه للبوست اوبراتيف هيموريج جريد اي كان 5 كيسز ودي تريتد كونزرفاتيفلي. الجريد بي كان 15 كيسز 5 كيسز نيد ري اكسبلوريشن. وجريد سي كانوا 9 كيسز خدوا برضه ري اكسبلوريشن ودول كانوا برضه ديو تو البنكرياتيك فيستولا. البيور بايل ليك ان 7 كيسز بيكتيل انسيرشن و 3 كيسز اتعمل لهم ري اكسبلوريشن. الجي اي تي ليك كان ان 8 كيسز ودول اتعمل لهم ري اكسبلوريشن كانوا بسبب جاستروجينوستومي وكان في about 2 كيسز من الجيجينوستومي. الوند انفكشن occurred in 50 cases take medical treatment. الوند هيسنز والبرست occur in 35 cases. Some cases done bedside wound closure واللي اتعمل لهم سيرجيكال كلوجر كانوا مع اسوشيت مع البنكرياتيك فيستولا. الابدومينال كولكشن والبريزن اوف ابسز تعمل لهم بيكتيل انسيرشن او ري اكسبلوريشن مع الحالات اللي هي الفيستولا مع نحط درينز في الابدومين. البلور افيوجن والشيست انفكشن اوكرد ان 15 بيشنت في منهم خدوا ميديكال تريتمنت و 5 كيسز نيد تو انسيرت بيكتيل في البلور افيوجن. الايرلي بوست اوبراتيف مورتاليتي this was in first months occurred in 27 cases. 18 cases patient due to sepsis و multi organ failure after re-exploration for pancreatic leakage and lavage. 4 cases due to cerebral stroke. 2 cases patient due to sudden cardiac arrest و 3 patient from massive pulmonary embolism. If we classify this complication according to Clevian score, grade 1 150 complication, grade 2 68 complication, grade 3A 35 complication, grade 3B 28 complication. جريد 4 23 وجريد 5 27. Conclusion, post-pancreatic duodenectomy remain a complicated surgical procedure that can significantly impact patient's subsequent quality of life. There is still no standardized technique for safe pancreatic anastomosis to prevent post-operative pancreatic fistula. Despite the observed decrease in post-operative mortality, morbidity has remained essentially unchanged, with most large series reporting from 35 to 45% major complication rate following pancreatic resection. Cleveland classification allowed to present a uniform way of reporting result, compare result of two distinct time period in single center, comparing result of surgery between different centers, compare result of surgical versus non-surgical therapies, identify objective preoperative risk factor, establish preoperative prognostic score. Standardization in reporting negative outcome will also be valuable tool in prospective studies in new therapies. Thank you.
Thank you. Thank you, Professor Amr, for this collective data about types of complication. الأستاذ الدكتور عمرو مصطفى، يعني رئيس أقسام جراحة الكبد وزرع الكبد في معهد الكبد جامعة المنوفية. شكرا جزيلا. Now may I call Dr. Mustafa Bouzid. He will present a case. He is here.
المحاضرة موجودة بس هو ما
جاش.
It's my pleasure now to present one of the pillars of liver surgery in Shams University, our dearest fellow and colleague, Professor Dr. Muhammad Fathi. He is welcome to present the Whipple operation, how to improve the results. أهلا يا محمد.
في البداية طبعا أشكر دكتور محمد أبو وهاب على الدعوة الكريمة، ودكتور طارق إبراهيم، ودكتور طبعا خالد فيه أستاذي على التقديم الجميل دوت، والتشير بيرسونز طبعا دكتور عاطفي. الحقيقة النهاردة بنتكلم على الويبل أوبريشن، ودايما بقول كلمة غريبة شوية، بحس إن الويبل عملية فيها حاجة غلط، يعني او البنكرياتيك كانسر بصفه عامه من العمليات اللي في حاجه في الطب عندنا فيها مشكله ليه؟ لان مفيش ديسيز بنعمل ريسكشن ميجور ريسكشن، يعني ياخد كيموثيرابي واقول له بعد العمليه اي اكسبكت 70% ريكارنس. ما عندناش في الجراحه كلها اعتقد حاجه كده، which means ان في حاجه ديفينتلي غلط، يا جزء تكنيكال مننا يا جزء في الكيموثيرابي. عشان كده العالم كله بيفكر في هذه القصه. الحقيقه اهميه البنكرياتيك كانسر 3 نقط سريعه كده. اول حاجه الكولكتيف 5 year سرفايفل 8.5%، رقم مؤسف جدا. النقطه الثانيه لو بصينا في امريكا في 2021 عندهم 60,000 حاله بنكرياتيك كانسر. الرقم الاوحش منه بكتير ان من 60,000 ده 40,000 او 48,000 ماتوا. بالاضافه ان الرقم بيزيد كانستنس، ودي اكسبكت ان 2030 هيبقى ده leading cause of cancer related deaths. وبالتالي احنا قدامنا مشكله ولازم فعلا نحاول نتعامل معاها. الاونلي كيور لو انا بتكلم على potential في كيور ما عنديش الحقيقه غير الويبل اوبريشن. نفسي في الويبل اوبريشن انا اوصل الى ترو ار زيرو، وكلمه ترو ار زيرو هنشوف ان هي مشكله كبيره جدا. مشكلتنا ايه في الريسكشن بتاعت الكانسر هيب بانكرياس والويبل؟ ان الهيد اوف ذا بانكرياس محشوره قوي ما بين السوبيريور ميزنتريك ارتري والسوبيريور ميزنتريك فين، وبالتالي ان انا اخد سيفتي مارجن في احيان كتيره ما بقدرش اوصل ليها. ولازم نعرف يعني ايه ترو سيفتي مارجن. على الرغم من كل الكيموثيرابي اللي احنا اتعدل كتير في الفترة الأخيرة، ولكن الحقيقة 80% من العيانين بيجي لهم recurrence within 2 years، وبنتكلم إن الأوفر أول سرفايفل
بنتكلم في حوالي 28 months، وبالتالي it is a devastating disease فعلا. الريكارنس بيبتدي في معظم الأحيان من 70 ل 100% من الحالات it's a local recurrence، ثم بعد كده يظهر لي ميتاسيس في حتة سواء بيريتون أو لانج أو ليفر. إيه أسباب الريكارنس؟ ما احناش عارفين، ولكن يقال إن incomplete lymph node dissection، البيرينيورال انفيجن اللي بيحصل مع التيومر، وعشان كده يمكن الحاجات دي اللي بتخلينا نحاول نتجه to be more aggressive شوية، يمكن نحسن هذه الريكارنس. العيانين اللي ماتوا من كانسر هيد وبعد ويبل اوبريشن وعملوا بوست مورتم 100% كان عندهم لوكال ريكارنس، which means ان اللوكال ريكارنس ده فاكتور مهم جدا في النتائج بتاعتنا. طب انا كجراح اقدر اعمل ايه؟ الحقيقه اقترحوا حاجات كتير، او ظهر في الفتره الاخيره شويه حاجات، من ضمنها what we call it the total mesopancreatic excision والفينس ريسكشن والتريانجل اوبريشن كموديفيكيشن في الويبل اوبريشن. سريعا التوتال ميزوبانكرياتيك ريسكشن الحقيقه هي جت من الناس بتوع الكولون لما عملوا توتال ميزو ريكتال اكسجن واثبتوا ان هي فعلا حسنت النتائج، فكان عندنا هوب ان احنا لما نعمل هذه القصه ناخد نفس نتائج الكولون. هي كانت فيرست ديسكرايبد الحقيقه من الثمانينات مش او التسعينات، مش من فترات طويله قوي، وهم ديسكرايب ويل فاسكولايز ستراكشر يحتوي على ليمفاتكس ويحتوي على الليمف نود اكستندنج ورا الهيد اوف البانكرياس لغايه الفيسلز، وهنشوف الرسمه بتاعتها. ده وات وي كول ذا ميزو بانكرياس. والحقيقه الميزو بانكرياس ده غير مفهومنا شويه في السيرجري بتاعت الويبل، ان مش بنقطع عند الهيد اللي هي مكان البورتال فين او سويمزنتريك فين، لا I have to retract الفين و have to expose الارتري، وانا هشيل كل التيشوز مش حتى اللي جنب الارتري، لا الليفل بتاعي الرايت سايد والانتيريور سيرفيس اوف الارتري، كل هذه التيشو should be removed. والايم بتاعنا ان احنا نوصل للار زيرو ريسكشن. الجزء الثاني والحاجه اللي يمكن بتخلينا في الجراحه ما بنشيلش كومبليت ريسكشن، خوفنا من ان الفين يكون انفيدد او الفين افكتد. والحقيقه حته الفين دي ظهرت من 30 سنه، لكن it takes 20 years لغايه ما تبقى a standard procedure معنا. ان احنا نقص البورتال فين سوبيريور ميزنتريك فين ونعمل ريكونستراكشن دلوقتي اصبحت شبه روتينيه في السبيشاليزد سنتر طبعا. ويمكن مشكلتنا ان احنا نقول هو امتى الفين اتاثر، لان طبيعي لما الاقي عندي ماس في الهيد والفين لازق فيها الاقي فيه ابارتمنت، طب هو ده زقه بس ولا داخل جواه؟ الان سي سي جايد لاينز بتقول ان انت لو شكيت قص الفين وفي شويه علامات زي irregularity في الفين دوت، او لو لقيت فيه سيجمنت اوكلوجن او ابارتمنت اكتر من 180 في الحاله دي كلها you should resect the vein. طبعا عندنا تكنيكس عشان ما نضيعش وقت كتيره قوي how to deal بساوند ريكونستراكشن او نحط بروسيسز وان كان نتائجها ما تبقاش حلوه قوي، وده الديفرنت تكنيكس بتاعتنا في الفين. التريانجل اوبريشن، التريانجل اوبريشن دي كان ديسكرايبد باي بوشلر في المانيا، والحقيقه هو بيقول ان انا عندي في تريانجل معمول من السوبيريور ميزنتريك ارتري ومن السيلياك ترانك ومن البورتال فين، وبالتالي في الويبل اوبريشن لازم اطلع سوبيريور ميزنتريك ارتري سيلياك ترانك والبورتال فين وكلير ذيس تريانجل. لما عمل هذه القصه الاستادز عندهم قللت اللوكال ريكارنس من 40% ل 20%. الحقيقه انا معاه جدا في هذه النقطه. يمكن احنا عندنا عاملين حوالي حاجه و60 عيان بالتريانجل اوبريشن، اللوكال ريكارنس لا يتعدى ال 10% عندنا. عندي بقى ليفر ديسس كتير، عندي بيرتونين ريديوز كتير، ولكن فعلا اللوكال ريكارنس قل مع التريانجل اوبريشن. ودي صوره بتاعت التريانجل اللي هو البورتال فين والسيلياك ترانك والسوبيريور ميزنتريك فين. مش هنضيع وقت كتير في الفيديوز، بس انا عايز
ده البورتال فين وده السوبيريور ميزنتريك فين. ادي قطعة البنكرياس وهنا السبلينيك فين. ده طبعا الهيباتيك ارتري.
ممكن نخش على الفيديو التاني كمان كده اوضح. يعني دايما لما نيجي نسلك انا بجيب الليفت رينال فين، فوق الليفت رينال فين تلاقي سيوزنتريك ارتري، نمشي معاه لغايه ما يوصل لغايه الاورطه. انا كده اطلع قدام الاقي السيلياك ترانك. لازم اكسبوز التراينجل دوت اللي هو معمول ما بين السيلياك ترانك سيوزنتريك ارتري اند بورتال فين، وتبقى كل الاريا دي كليرد.
هما الاثنين
اللي احنا معلقينهم دول التيب اللي تحت ده سبينوزنتريك ارتري واللي فوق ده سيلياك تراك. ده حاجه لو عندي بورتال فين ساعات نعمل له بس جاست قطعنا جزء من اللاترال وول بتاع البورتال فين، وممكن يجي ريكونستراكشن من غير ان انا اقصه اند تو اند انستموزس. هنا ده كان عيان احتاج ان احنا نعمل كومبليت ريسكشن للبورتال فين او سبيمزنتريك فين، وكان لور تحت شويه عند بدايه السبيمزنتريك فين بالتو برانشز بتوعه. وده ريكونستراكشن. الحقيقه احنا كنا بنخاف من القصه. لا اتس فيري سمبل ان اتس وايد انستموزس، مفيش فيه مشكله خالص. وعشان برضو الوقت دي الصوره بعد ما عملنا دي كلامبنج. الانستموزس موجوده اهوت عند التو برانشز الايليال والجيجنال برانش بتوع سبيمزنتريك مع سبيمزنتريك نفسه. الكونكلوجن بتاعنا positive resection margin in pancreatic cancer is associated with poor outcome and it is an independent prognostic risk factors. والحقيقه كان في ستادي كتيره بتتكلم على البوزيتيف مارجن، ما هواش زي ما احنا فاهمين ان هو الحته اللي انا بقطع فيها فقط، لا دي الحته اللي هي ملامسه او قريبه من السوبير ميزنتريك فين وارتري. وكان في ستادي جميله قوي واحد عملها يشوف الانسنس اوف ا ترو R0 كام عيان متعمل ويبل، وكان بيعلم مكان الفين ومكان الارتري، لقى ان الترو R0 is 20%. ولو فاكرين ان الريكارنس 80%، which means لو حطينا الرقم ده مع الرقم ده يبقى يمكن جزء كبير من اللوكال ريكارنس حته ان احنا ما بنشيلش كل التيشوز اللي هي اكستندنج من عند الفين والارتري. Total mesopancreatic excision is a real surgical concept that should be standard for any pancreatic endarterectomy because it is a safe، حاجه سهله ما فيهاش اي حاجه، feasible and allow increase the number of lymph nodes. احنا دايما في الويب بنلاقي عندنا 23 و24 وساعات 30 lymph node في السبيسمنت. عشان كل ده we hoping ان احنا نوصل ل the true R0. Venous resection during surgery for pancreatic cancer can be regarded as a standard procedure in experience and should be performed routinely. لو انا شكيت ان في invasion ولا ما فيش، لا نقصه ونوصله افضل بكتير ما اسيب residual tumor ورايا. الترينجل operation carries the hope of decreasing local recurrence which will be reflected on the patient survival. Thank you.
Thank you, Professor Dr. Fathi, for your excellent presentation. And we'll leave the discussion after because your presentation. عايز سؤال؟ نعم؟ طب دكتور فتحي طارق، طب أنا هسأل معلش أنا أقول حاجة بس. هو الحقيقة أنا would like to add، طبعا ده اللي أنت قلته ده حضرتك ده كلام جميل، وإحنا we would like إن إحنا نابلاي في كل السنترز وبانكرياتيك سيرجن in Egypt. وعشان كده في بره دكتور فتحي يقول لك ان انا عشان تو بي ويبل سيرجن او بانكرياتيك سيرجن لازم اعمل 1 ويبل اتليست بير مانث. دي الامريكان سوسايتي اوف بانكرياتيك سيرجنز، مش انا اللي هعملها ولا عارف.
وفي ناس بتقول اكتر من كده. في ناس حطوا قالوا في ناس قالوا 30
اللي هم ام دي اندرسون والميموريال بتاع نيويورك. قال لك لازم اتليست زي ما مثلا ما يقول لك الامريكان ثيرويد اوف ثيرويد سيرجري، تقول لك عشان تعمل توتال ثايدكتومي لازم تعمل 25 بير يير بالظبط كده. فاحنا يعني طارق عايز تقول حاجه؟ دكتور عبد الوهاب بيه.
اتفضل دكتور محمد، اتفضل.
هو طبعا موضوع مادك وفي ديفيكالت، انما سنه 2001 انا ببلشت موديفيكيشن للويبل، موديفايد ويبل، وباسمي منشور. كان لجداكس اللي هو سكرتير الجمعيه، انا كان عنده حاله تروماتيك ديودينال تروما وعرضها، وبعدين بيشتغل وقلب الديودينا بالهيد تو ذا اذر سايد وديسكت البورتال فين فروم اباف داون، وجاب الارتري وشال، عمل ويبل للحته دي. انا جيت بدات افكر، عملت موديفايد تكنيك اللي هو تستارت فروم اباف، تشيل الجول بلادر وتشيل الدكت وتنزل لغايه الديودينم وتعمل كوخرايزيشن للديودينم بالهيد وتقلبه على الناحيه الشمال. هيبان قدامك البورتال فين، هتجيبه، هتقدر تديسكت الانسينيت بروسيس فيرست بين البورتال فين والارتري واسكلوتونايز الارتري قدامك، ويبقى الهيد مع الانسينيت بروسيس لغايه النيك وان ماس. والحقيقه يعني مش هقول ان الريكرنس بس ايه، it is comparable اللي هو دي سموها بوبيسكو في رومانيا، اللي هو ميزنتري اكسجن او زي اللي هو البنكرياتيك ميزنتري وبتاع، وعملوها في البرازيل. انما خدوا الفكره دي من الموديفيكيشن، والحقيقه عملوا راندومايزيشن ووجدوا ان التكنيك ان انت تشيل الميزنتري وتشيل الانسينيت كومبليتلي من الارتري بيدي الى حد ما يعني بروجنوزس احسن من انك تبدا انتيرورلي وما تقدرش تجيب الانسينيت، لان ساعات بيحصل بليد له مشاكل. فهي فعلا انك تشيل الانسينيت كومبليتلي مع الميزنتري بتديك الى حد ما جود بروجنوز. وانا بشكر سعادتك.
تمام، شكرا يا بيه.
هو طبعا الدكتور محمد الموضوع ده شيق جدا. انت في البدايات اما بتتكلم ان عمليه الويبل دي عمليه يعني حاسس الدنيا مش مظبوطه، طبعا انت عندك حق، لان هي مش راديكال سيرجري، هي سيرجري بس از نوت راديكال سيرجري، معناها هي موضوع يعني عمليه كبيره قوي. تاني حاجه، انت لما قلت الجماعه الامريكان انت طلعت التلتين بيحصل لهم ريكارس، تمام؟ طب انا عايز رايك ايه ان في بعض السنترز لما بياخد الليمف نودز لو لهم بوزيتيف ما بيعملش ويبل، بيعمل باي باس خلاص، لحد اللي بيعمل بورتال فين ريسكشن، لحد الارتري ريسكشن، لحد وان سنجل ميتاسيس في الليفر. Do you think it's worth it at the end to go for this surgery ولا you go very simple once lymph nodes are positive you just do bypass؟
يعني الحقيقه
بس
السؤال هيبقى فيه كذا فاكتورز كتيره قوي. لازم نحط في اعتبارنا ان البنكرياتيك هيد بالذات من الحاجات اللي حتى لو ما عملتش عمليه الكواليتي اوف لايف سيئه جدا. البين بتاع البنكرياس فظيع لدرجه ان في ناس بتعمل بالياتيف ويبل كباليشن للعيان دوت. ولكن طبعا هنحط في اعتبارنا كذا نقطه. هل انت بتعملها سيفلي؟ يعني زي ما دكتور عاطف بيه قال ان عشان تبقى بنكرياتيك سيرجن 10، والحقيقه ده في ناس بتتكلم في 30 في السنه، وفي ناس وصلت ل 50 في السنه عشان تقول I'm pancreatic surgeon. فهي دي الميزان، ان انت وازن الهازارds بتاعت العمليه من البنفيت بتاع العيان. الليمف نود هي بروجنوستيك باد، بس اعتقد الكيموثيرابي وابتدوا يدوا دلوقتي لوكال راديو ثيرابي ليها ممكن تحسن النتيجه. كومبيرنج بعيان انا بتكلم السرفايف بتاعه لن يتعدى سنه، لكن لو انا عملت القصه دي وحتى وصلت 28 شهر فده مش وحش. دكتور عواب كان معترض على السورافينب والكلام ده. السورافينب احنا عارفين انه بيحسن السرفايفل من 9 شهور ل 12 شهر، 3 شهور. ده دواء اللي عمل ضجه في العالم كله. فانا لو عندي بروسيدر هيحسن لي من سنه لسنتين ونص اتس worthy، بس شرطه انه يكون سيف.
لما بتعمل ويبل بقى في ريكارنس بعد كده، فالريكارنس جوندس فري بين فري.
بالظبط بالظبط.
زي ما انت الكامل بس انت طبعا ممكن تو افويد البين بحاجات
دكتور طارق نفس الدسكشن
يا جماعه بس خلاص كلام حلو
معلش بس التايم
ايوه بس يعني بتكلم مع راجل بيتكلم كلام كويس.
بس احنا وي ار نوت ان بانل ديسكشن.
ايه
دي مش بانل ديسكشن.
مش بانل بس يعني يا جماعه انا اعتقد الكلام يعني مش عارف ما هو الناس يعني بالتالي مستفيده من الكلام يعني. فانت ممكن تو اوفركم البين والجوندس بطرق ثانيه،
سيلياك بلوك والحاجات دي طبعا.
اوكي شكرا دكتور فتحي.
شكرا.
Our next speaker from the south of Egypt, the known oncosurgeon دكتور علي زيدان. اهلا بيك. لا مش طارق، خلاص طارق تعال انت ادير الجلسه.
ثانك يو مستر تشيرمان، وبشكر استاذ الدكتور عبد الوهاب على الدعوه وبهنيه برئاسه الاتحاد العالمي. ان شاء الله المؤتمر السنه الجايه يكون عالمي فعلا. انا هكمل الكلام بتاع استاذنا الدكتور محمد فتحي عن التراينجلر اوبريشن في البنكرياتيك كانسر. وفعلا معظم الستاندرد بنكرياتيكتومي او اليوجر بنكرياتيكودونيكتومي بيكون في بوزيتيف ريسكشن مارجنز اب تو 80%. طبعا البنكرياتيك كانسر عم يتقسم ل يعني اوبرابل او بوردر لاين او لوكالي ادفانسد، واصبح دلوقتي في البوردر لاين ولوكالي ادفانسد ريجونال نيو ادجوفانت كيموثيرابي ستاندرد اوف كير. والتراينجلر اوبريشن لما بدات مع الحالات البوردر لاين ولوكالي ادفانسد بعد النيو ادجوفانت. دلوقتي ايفن حتى الاوبرابل بنابلاي التراينجلر اوبريشن. يعني احنا طبعا بعد ما بننهي الكيموثيرابي الاسسمنت احنا السي تي ما بيكونش valid 100%. You can depend in tumor marker in PET CT. You can do a diagnostic laparoscopy, and finally you advise to do go ahead directly for pancreaticodenectomy if CT still after 6 weeks of neoadjuvant chemotherapy questionable. Venous resection, now pancreaticodenectomy is classified into 4 types. Standard pancreaticodenectomy is type 1, type 2 pancreaticodenectomy with venous resection, type 3 pancreaticodenectomy with multivisceral resection, and the type 4 is pancreaticodenectomy with arterial resection. Some centers like Japan do arterial resection, but we are in Egypt and in Cancer Institute still does not do arterial resection. As regard lymphadenectomy and extended lymphadenectomy does not add to survival, but it is a prognostic factor. Triangular operation, it is not an extended lymphadenectomy. As Dr. Fathi said, around the head and uncinate process of pancreas, there is a lymphatic, there is a perineural, there is a connective tissue. You should remove all this fibrofatty tissue. It is called R0. And now R0 you should resect. It is a retroperitoneal and it should more than 1 millimeter. Like cancer rectum, it is called circumferential margin. Another type of arterial divestment, you know the wall of the artery, it is tunica adventitia, tunica media, tunica intima. You should, after neoadjuvant chemotherapy, in a proper place between the tunica adventitia and remove all fibrofatty tissue, and you should do frozen section to sure it is a viable tumor or it is a fibrosis. Triangular operation, it is arterial sparing operation. You spare the superior mesenteric artery, the celiac artery, the hepatic artery, and celiac trunk. At the same time, you remove all the connective tissue and the perineural tissue, and actually there is a main cause of recurrence. Last 2 years, I bought a talk in this conference about superior mesenteric artery first approach. Some center go ahead directly, even for borderline and for locally advanced pancreatic cancer, for upfront surgery. Triangular operation, it is potential improve overall survival and recurrent-free survival, and it is sure decrease the local recurrence. Mesopancreas, and Dr. Muhammad covered the mesopancreas. We must reach R0 section. We must reach more than 1 millimeter safety margins. R1 is equal inoperable. If you can't reach sure for R0, don't go ahead for a Whipple operation. You should or you must remove all perineural and gross tissue. Sure, you can, some patient developed of diarrhea because you remove nerve plexus, but it is improved within 3 weeks by lopramide. Local recurrence after standard pancreaticodenectomy is 20%. After triangular operation is 0, and survival rate without triangle, without radicality, only 5%. It is improved and reach in some paper up to 40%. It is higher blood loss and longer duration of surgery, improved by learning curve. As regard a complication, it is no add complication, and triangular operation is visible and safe. Pancreaticodenectomy, now we can do it by minimal invasive, either laparoscopic or robotic. There is actually a coherization of duodenum, and you can reach the aortocaval. And if there is a lymph node in the aortocaval, you should send it for frozen. If it is positive at aortocaval, you stop the procedure. Then after we do coherization of duodenum, there is aortocaval and complete exposure. Sure, there is no lymph node. There is a porta hepatis lymphadenectomy completely. You can start from celiac trunk, from superior pancreatic region. There is a trifurcation of celiac trunk. There is a proper hepatic artery, complete lymphadenectomy. I prefer to do extended lymphadenectomy, but again, triangular operation is not extended lymphadenectomy. By this advanced and extended lymphadenectomy, we can remove up to 40 lymph nodes. We cut the common bile duct, and there is actually the gastroduodenal artery. There is a mesopancreas. As you see, there is actually a ligament. After I reach from the inferior vena cava, left renal vein, I reach the origin of the superior mesenteric artery, and as you see, there is a ligament actually, and there is a mesopancreas. You should complete, clear, and resect the mesopancreas, and there is a retroperitoneal margin or posterior margin, and there is a actual of recurrence. If there is a suspicious of venous infiltration, you keep it until the last. There is a IVC, left renal vein, organ of superior mesenteric artery. There is a superior mesenteric artery first approach. You should remove all at least 180 angle, remove all fibrofatty tissue until the organ of inferior pancreaticoduodenal artery, which arise from the superior mesenteric artery. And by this superior mesenteric artery first approach, you can preserve the time if the cancer head is inoperable. And there is actually the triangular operation, superior mesenteric artery, celiac trunk, and I can use ligashore or harmonic, and this add. There is actually the triangle. You see the triangle, superior mesenteric artery, portal vein, and celiac trunk, I clear it completely. There is actually all local recurrence occur in this triangle. It is done routinely in Heidelberg. There is a gastroduodenal artery. I advise to put a hemolock. If there is a pancreatic fistula, you avoid blowout. Another case of triangular operation, I retract completely the portal vein, and there is the superior mesenteric artery and the celiac trunk. Third case, I explore there is a first jejunal vein. You should ligate the first jejunal vein and complete clearance of triangular area, all fibrofatty tissue and connective tissue and the perineural tissue. There is a first jejunal vein. You should explore the anterior and right side completely of the superior mesenteric artery, as I said, at least 180 degree to be completely. Fourth case of triangular operation, there is a portosystemic vein. There is a triangle is obvious here. There is IVC, left renal vein, organ of the superior mesenteric artery. I completely clear of the triangle. By time and by you can improve your level and does not add to morbidity or mortality. It is add only about 20 minutes complete clearance, and you should sign this for pathologist to determine it is a retroperitoneal or posterior margins to sure it is actually a negative, and you should resect the specimen in block or in mass, and you can send this posterior retroperitoneal segment separate or unblock with sign to pathologist to sure it is a negative margins actually. There is 4 years after a triangular operation with pancreaticogasterostomy, as I do routinely, and there is no evidence of local or distant recurrence. Thank you.
Thank you, Professor Ali, for your nice and illustrative presentation. We'll make the discussion at the end of the session, Dr. Ali. May I call, and it gives me a great pleasure for my friend, Professor Talat Shahawi. He's going to present the surgical resection of insulinoma. هذا دكتور طلعت. فيديو برزنتيشن مش كده دكتور طلعت؟
Bismillah ar-Rahman ar-Rahim. First, I want to thank Professor Muhammad Abu Wahab for this successful conference and for his kind invitation. Thanks to Professor Atif and Mr. Chairman. Thanks to my colleagues. Laparoscopic management of insulinoma. الحقيقة دي حالة كانت معايا من 3 months، ودكتور محمد من يومها لما شافها معايا قال لي جهزها نقدمها في المؤتمر. Insulinoma is a functioning neuroendocrine tumor. Neuroendocrine tumors arise from hormone-secreting cells and nerve cells mainly located in GIT and respiratory tracts. Gastroenteropancreatic neuroendocrine tumors affect GIT and pancreas and are classified as functioning tumors and non-functioning ones. Pancreatic neuroendocrine tumors are further divided into 3 categories according to WHO 2017 classification. Well-differentiated neuroendocrine tumors, poorly differentiated neuroendocrine carcinoma, mixed non-neuroendocrine neoplasm. Functioning pancreatic tumors include insulinoma, gastrinoma, glucagonoma, lipoma, and somatostatinoma. The commonest is insulinoma. Incidence of insulinoma, it is the most common pancreatic functioning neuroendocrine tumor. It is derived from beta pancreatic islet cells that secrete insulin. Insulinomas, fortunately, Majority of insulinomas up to 95% are benign tumors. Only 5 to 10% are malignant. Insulinoma account for 1 to 2% of all pancreatic tumors, affect approximately up to 3 patients per million per year all over the world, may occur at any age, mainly during the 5th decade of life. It has slight female predominance. The clinical picture classically presents by Whipple triad, symptoms caused by hypoglycemia as palpitation, sweating, and fainting, low blood glucose level during the attack, symptoms relief after administration of glucose. The diagnosis depends on biochemical tests. Insulinoma diagnosis combined these 6 criteria. Blood glucose level less than 40 milligram percent, insulin more than 36, peptide more than 200, proinsulin more than 5, beta hydroxybutyrate less than 2.7, absence of plasma or urine sulfonylurea metabolites. Second test is 72 fasting test, considered as gold standard for confirmation of insulinoma. Consecutive blood glucose and insulin level measurements until the patient becomes symptomatic. Most patients, about 80%, develop symptoms within 24 hours and are admitted to hospital in order to undergo serial insulin and pro-insulin determination. Tumor localization, CT scan. It is considered first line imaging technique. Magnetic resonance imaging is emerging as an appropriate, safe, non-invasive alternative for CT scan with high sensitivity in the localization of insulinoma and metastatic disease. The pattern of enhancement is attributed to the classic hypervascularity of these tumors. SASI test, selective arterial secretagogue injection. The sensitivity of this test up to range from 84 to 100%, and is the most sensitive method independent of tumor size in localization of tumors preoperatively. Endoscopic ultrasound, the sensitivity range from 70 to 95%. It is a test of choice in case of inconclusive results in the aforementioned first-line imaging techniques. The treatment of insulinoma may be non-operative treatment. Actually, the treatment of insulinoma is surgical, and patients should be operated only if the diagnosis is confirmed. One of the most important aspects in the prevention of severe hypoglycemia symptoms through frequent meals and certain drugs as diazoxides and other drugs as streptozocin and verapamil and phenytoin. The surgical treatment is the treatment of choice. Surgical management is the most widely accepted treatment. Surgical procedures include enucleation, procedure of choice especially for small-sized tumors. Pancreatectomy, it is indicated in large tumors, high suspicion of malignancy and metastasis. Procedure, distal pancreatectomy in tumors of body and tail, Whipple operation tumors of head, and central pancreatectomy in tumors of isthmus and body. The prognosis, approximately 90 to 95% of insulinomas are benign, with expected 5-year survival up to 100%. Relapse has been reported to be at level of 3 to 5% in previous large series. Metastatic disease, patients may develop metastatic disease several years after excision of insulinoma, initially considered to be benign. The relapse risk is more probable in grade 2 tumors. I will present this case. 20 years old male patient presented to our center with history of recurrent attacks of tremors and palpitation of duration of 6 years. He had no family history of endocrine disease. Physical examination showed healthy man with body mass index 24. Laboratory investigation, low initial glucose level, 35 milligram percent, high plasma insulin level 50, and high C-peptide level 6.7. Abdominal computed tomography, demonstrated the lobulated inferior surface of the pancreatic body with a small ill-defined exophytic lesion displaying faint arterial enhancement, size 1.5 diameter. Regarding patient's history of hypoglycemia, insulinoma was considered. No liver metastasis, no lymphadenopathy. This is a picture of CT. AOS examination revealed a hypoechoic mass at the pancreatic body, about 17 by 15 millimeters, well-defined exophytic lesion from the inferior border of pancreas, mostly insulinoma, three superior mesenteric veins and splenic veins, and no liver mets. This is a picture of AOS showing the mass. It is separated from the splenic vein. The decision was for laparoscopic enucleation of this mass. By laparoscopy, we explore the pancreas by opening the lesser sac, and fortunately enough, the lesion was easily identified as exophytic lesion from the lower border of pancreas. As you see, this lesion. The video is not working, sorry. As you see this lesion, this is splenic vein, this is the lesion. This is the site of lesion after its section. This is the splenic vein. I am sorry for non-working video. This is the specimen after enucleation. Pathological examination revealed well-differentiated neuroendocrine tumor, grade 1. Immediately after surgical treatment, the glucose level increased to normal range. Patient was discharged without any hypoglycemic symptoms after 2 days. Repeated follow-up visits of the patient, no recurrence of symptoms with normalization of blood glucose level. Thank you.
شكرا للاستاذ دكتور طلعت على العرض والحاله الجميله، شكرا جزيلا. Remaining announcement by Professor Dr. Muhammad Abdul Wahab. After the next and the last speaker from London, he was postponed, not available yesterday from the first session. He will present a talk. After this talk, we will take a picture, all of us, with Professor Dr. Muhammad Abdul Wahab and Professor Tariq Ibrahim, inshallah, after 10 minutes. May I present Professor Dr. Rida from London, UK. He will present a talk about the outcome, the difference between open and laparoscopic liver resection, as there is effects on the function or the operative technique. Please go on.
Thank you so much. Well, I'm not yet professor. Thank you so much for this nice introduction.
Consultant, big consultant.
No, I'm specialty registrar in Kingston Hospital, NHS Foundation Trust. Trying to work hard to be consultant on Caesar pathway. But thank you so much. I will start presenting. So we have done a recent literature review and meta-analysis. It is for operative and hepatic function outcomes of laparoscopic versus open liver resection. And again, we published recently in PubMed, and it was a good one to elaborate the advantages of laparoscopic versus open. This is a PubMed ID if you want to visit the study. And liver resection, we will discuss about indications, standards for liver resection, objective of our literature review, the outcomes and methods, materials and methods, and then our results, and finally discussion and conclusion. So the indication of liver resection, as you know, is either primary or secondary, and mainly for primary hepatocellular carcinoma. At some point for cholangiocarcinoma for selected patients. Secondary colorectal metastasis when there is liver mets and it is amenable for resection. So you think about liver resection, and sometimes benign like liver cysts when the gastro decide that it needs resection, a benign adenoma, trauma, inflammatory pseudotumor. So you can do it for hepatocellular carcinoma or for colorectal cancer with metastasis. And the utility of liver resection extends across a broad spectrum of clinical scenarios beyond its well-established role in imaging of malignant liver tumors. And before you decide, of course, you will have like upper or hepatobiliary center to decide that this patient needs hepatectomy. The standards for liver resection, the known standards now are like open or laparoscopic, and upcoming with the introduction of AI and robotic surgery, it will have potential to be in the future, applied in the future. The objective of our study is to study so it's a comparative study between the outcomes, including complications and hepatic function, in terms of doing hepatectomy via open technique or laparoscopic technique. And apparently the outcomes that our comprehensive research, we involved 3,192 relevant records, and finally we involved only 9 randomized controlled trials, finally purified and filtered. And we find that laparoscopic resection exhibited reduced operative bleeding, intraoperative bleed, shorter hospital stay, and less wound infection, and the risk of complications was significantly lower in the laparoscopic group with a risk ratio of 0.57, and the 95% confidence interval was 0.43 to 0.76 with p-value of less than 0.0001. And for Cleveland-Dindu classification degree 1 and 2 complications, the laparoscopic patients had lower post-operative complications. Also for the hepatic function in terms of bilirubin, ALT, and AST, the laparoscopic group had lower post-operative AST levels at day 1. So we collected the data from PubMed, Scopus, Cochrane, and Web of Science, and we've done the identification of studies via database, and we finally purified all of this after excluding conference abstracts, non-randomized controlled trials. We excluded the non-English ones, and we concluded 9 randomized controlled trials. Let me illustrate. Hopefully it will be clear for all of us. From China, we included Deng et al. 2015, and it was study protocol local committee, and it was for hepatolithiasis within the left lateral loops, and the operative and the primary outcome is to compare the operative and complication outcomes. And they reported that laparoscopic resection for left lateral hepatolithasis was as open surgery, but offered less operative time, less bleeding and well bleeding control, and less hospital stay. From Egypt, El-Jendi et al. 2017, and it was local committee for hepatocellular carcinoma and laparoscopic hepatic resection outperformed the open resection with, again, significant shorter hospital stays and no compromise in the oncological outcomes as well. For colorectal liver metastases, we involved from Norway, Fritland et al. And in 2017, this study was for colorectal liver mets. And the primary outcomes for looking for complications of hepatectomy, and patient underwent parenchyma-sparing liver resection for colorectal metastases. Laparoscopic surgery resulted in significantly fewer post-operative complications than open. So I will leave it for you on the presentation. Like as you can see, most of them, like the largest one of them was about, like the multinational one was here, Wong et al. 2017 for colorectal liver mets as well. And the study was not able to conclude on time to functionality recover. And again, we have a look at the sample, and we found that one of the big sample size was Fritland et al. 2017, and it involved 133 laparoscopic and 147 open resection. And as we said, we measured the ASA grade, and if we come back to this study, it was about colorectal liver mets. And again, they found that laparoscopic outperformed the open technique. For quality assessment, the quality of the included study varied, and the 3 studies were rated as having some concerns. Liu et al. 2015, Yan et al. 2020 showed some concerns in terms of randomization process and deviation from intended intervention domains. And as you can see here, the bias arising from the randomization process, as you can see, the studies put in like with overall risk of bias, and here you can see some concerns are there, but not massive concerns. The results conclusively, as you can see here, in terms of operative time, in our randomized control trial in El-Jendi and the other 9 studies that we involved, there were no significant difference between laparoscopic and open. Amount of bleeding, the amount of post-operative bleeding was less in terms of laparoscopic group. So that's the overall operative time. Again, no significant difference. In terms of amount of blood loss, the amount of blood loss was less in laparoscopic, of course. And you can see here in length of hospital stay, most of the studies favor laparoscopic resection. So you can see the main difference of these studies. Most of them actually favors laparoscopic resection. Intensive care unit admission. There were, if we can go to intensive care admission, there were no significant difference between the need for ITU admission because the criteria is the same. So if this patient will require post-operative ITU, then we decide the patient will go to ITU to have post-operative optimization, so there were no big differences. Specific complications in terms of wound infection, again, laparoscopic was less.
2 minutes, Dr. Reda. 2 minutes.
Of course.
Yes, continue, please. Dr. Reda.
Of course. So in terms of Cleveland classification of complications, there was lower risk of degree 1 and 2 Cleveland-Indo complications in the laparoscopic group compared with the open. So overall, as you can see, most of the studies favors the open in terms of postoperative complications. So we involved again these 9 studies, and our findings underline that the laparoscopic resection offers numerous advantages over the traditional open approach. And in terms of reduced intraoperative bleeding, shorter hospital stay, lower risk of complications, and moreover, laparoscopic resection exhibited a superior outcomes in terms of liver function markers. I didn't involve it, to be honest, just I tried to be brief, but you can visit the PubMed and see it. Again, the laparoscopic overall improve the survival and perioperative outcomes significantly. And notably, the research contributed valuable data to support the efficacy of laparoscopic resection in cirrhotic patients in Zeng et al. 2020, which was a recent one, reported similar results to ours. The most recent meta-analysis by Henry et al. Or Haney et al. Observed reduced complications, shorter hospital stay, and lower blood loss in laparoscopic liver resection. And my colleague Iyad from Sudan, he recently as well published a specific one about the bile leak and the blood loss, and as well laparoscopic offered more advantages. However, it's crucial to note that some of the included studies referenced were not reachable, potentially impacting the study's reliability. Also, they included abstracts that might lack detailed methodology and results, leading to incomplete conclusions in some studies. Future enhancements in the field may involve advancements in robotic training fellowships, standardization of surgical techniques, and comprehensive randomized studies. These improvements could position the robotic platform, as we said. We have published recently as well about the artificial intelligence role in surgical specialties, and they use it in colorectal cancer. They use even in blood bank and in blood sampling. They use it in gynecology, and if you like, AI is advancing now. So robotics and AI are coming. We don't know in what way or in what scope, but they are actually advancing. You know, you remember, like we started open, then laparoscopic, then now robotic. In some centers we work it here. So anyway, our evidence firmly advocates incorporating laparoscopic liver resection as a regular surgical practice if possible, and continuous research efforts are essential to delve deeper into the sources and enhance our current literature. And
conclude. Conclude.
So quickly, conclusion is that our analysis recommends the wider adoption of laparoscopic liver resection, and this is Sinai. Thank you so much.
Thank you, Dr. Reda, for this collective meta-analysis. And may I call Professor Dr. Abdul Wahab and all of us, the group picture, the first line, old age professors will sit in chairs, وبعدين the second line behind them standing, and the third line on the stage will stand. Very old will sit down on chairs. Very old. Young surgeon and students will come up to the stage.
بس الله يكرمك كده. لا ورا شويه، ورا شويه دكتور محمد، ورا شويه يا امير، ورا شويه عشان الصوره، ورا شويه يا امير عشان ما تبعدش عن الصوره، ما تبقاش كبيره. يا بنت خلتنا اقول لا هنقول ايه؟ مش هنقول حاجه. خالد متعود يقف. ايه؟ بالعكس، لا بالعكس بالعكس. ايوه يا جماعه، استنى اللي جاي، ما تيجوا اللي واقفين يا جماعه. خد يا محمد، محمد خالد. اكرم يلا يا جماعه، يلا يا محمد. تعالى انت بقى.